Morning. Is that Professor Bruce?
It is. It is. Hi.
Good morning. I'm Khurram Hassan.
Hi, Karen. Where are you at the moment?
I'm based in Lancashire, in north of England.
Ah, right, right. I've been
Okay,
there a few times.
brilliant. Thank you for joining, um, uh, and to all the participants. So I'd like to welcome all of the guests who are participating today, and for our esteemed speakers. And we've got a full program of specialists in their field taking part in this conference hosted by INTERYem. So just to repeat, I'm Khurram Hassan. I'm a GP based in the north of England, and I had the pleasure of spending 7 years in the Yemen in the valley of Hadramaut, practicing medicine there as well as learning Arabic. This conference is being held on Zoom and on YouTube. So for those for it's easier to follow on YouTube, you can type INTERYem into YouTube to find the channel. Today we've got just as yesterday, this is the second day of the conference. We've got a day packed with guest speakers who are specialists in their field, and they'll be delivering talks and also answering questions from our colleagues in the Yemen with regards to family medicine. And Professor Bruce Arrell, he's just waiting to give a speech and to deliver his talk on the effective management of anxiety and depression in family medicine. Closed captioning should be viewed on your screens. So for those who find it easier to follow, subtitles are available there, and to help with understanding what is being said. And the talks will hopefully remain on the internet for provenance, so you can return back to them in the future. INTERYem is the international network for training, education and research in Yemen that was set up in 2014 with a view to collaboratively helping and supporting colleagues in the Yemen in providing healthcare in extremely challenging circumstances. This conference aims to specifically help those who are specialists in family medicine, and to provide an update for our colleagues in the Yemen, but also for us outside of the Yemen to get a feel from the questions and answers and the various sessions, to get a feel for the challenges that our Yemeni colleagues are providing, are faced with, excuse me. This conference is a series of conferences that we hope to undertake in the near future. And for example, there's a planned conference on public health and infectious diseases. Just a bit of housekeeping before we start. If you don't mind just keeping your camera switched off and your microphones on mute. The program for this morning is that Professor Bruce Arrell will be speaking firstly about the effective management of anxiety and depression in family medicine, and there'll be a period of time for question and answers, and thereafter Dr. Steve Holmes will be speaking about the principles of managing conditions in family medicine. Please type your questions into the Q&A box on Zoom during the, and for those who have registered, there'll be opportunity for feedback, which is important for the organisers, and also there'll be for those who require certificates or any evidence of participation, they'll be able to request that. As with any conference, there are multiple sessions, some of which may be of more relevance and an interest depending on your expertise and your subspecialty. Please do identify which presentations would be useful for you to attend. And it's suggested that over the course of the 2 days, to get a certificate, you'll need to attend at least 75% of the sessions. So let me introduce Professor Bruce. He's a professor of general practice and primary healthcare at the University of Auckland in New Zealand, and a practicing GP at Greenstone Family Clinic in Manuva in South Auckland. Professor Bruce, I don't think I pronounced that correctly, have I?
It's a Maori name and it would be Manurewa, but no, good try, good try.
Oh, excuse me, Manurewa in South.
Manurewa, yeah. Even non-Maori speakers have trouble with it. So.
All right, good. He does regular general practice at the clinic and special consultations using focus, acceptance, and commitment therapy. FACT, for people who are feeling stuck in their lives by stress, pain, or low energy. Professor Harrell is also director of the Goodfellow Unit, writes the 2-weekly GEMS, and does research on non-drug treatment for mental health issues. He's also the head of the Department of General Practice and Primary Healthcare. Over to you, Professor.
Right, I'll just do my share screen. Is that right?
That's fine. I can see you there. Yes.
Yep. Okay, and hopefully that's come up now. Is that correct, Kiran? Can you see that?
I can see you. Yeah, I can see the slides well.
Good. Okay. So so thank you very much for this invitation. It was a surprise and a great honor to be asked to be able to speak to you. I've never been to Yemen. The closest I have got is Jordan. But I realize that's still a long way away from Yemen. And I am aware of what's been happening there. And I do hope that peace comes to your region. I cannot imagine what it's like to have to live when there's lots of fighting going on. So normally in New Zealand, I would show this map. You probably know where Australia is, but a lot of people think that New Zealand is part of Australia. But actually, we're 2,000 miles, or about 3,000 kilometers away. Although, interestingly, Auckland, which is there, Australia is so big that Perth is further from Sydney than Auckland is. So New Zealanders can get to Australia quicker than, or to Sydney quicker than people from Perth. The Maori name is Aotearoa, land of the long white cloud. And that's because it rains quite a lot here. We often have clouds over and above us. And again, if I was introducing myself, and we tend to use the indigenous language here, this is Auckland City, as you can see, a fairly modern city with a big harbour. And the mountain in the background, because I was born in the city, I consider it's my mountain. And in Maori, I would say it's my monga. So you would have understood that I was born in Auckland, and this is where my family come from. Actually, my original family come from Scotland. Errol is a Scottish name, came from Glasgow about 100 years ago. So most European people in New Zealand are migrants of one sort or another, and the Maori are the indigenous people. So anxiety and depression, I've been interested in this topic for a very long time because I've always struggled to sort out the two. And this is taken from a paper from a Dr. Baldwin, who I think is still in Southampton. He's a psychiatrist. Southampton has a very good primary care department. And this comes from 3 circles, and the one circle is anxiety, one circle is depression, and the middle circle, the middle column here, is where you have symptoms of both. And this is why it's very hard, particularly in primary care, to sort out the difference. There sort of is usually a little bit of both. If somebody's very anxious, they'll have a little bit of depression. If they're very depressed, they'll have a little bit of anxiety. And over the years, I've come to the point of view, actually, it doesn't matter in primary care. There's not much point in putting a label on somebody unless you need to put a label on somebody for referral purposes or insurance purposes or some administrative reason. And I say that genuinely because I believe that a diagnosis should be more benefit than harm to a patient. And certainly in our society, having a label of depression or anxiety, there's a bit of what we call stigma attached to it. And that can make it difficult for people. It can cost them money if they're looking to get insurance, and it can make it difficult to get jobs. Some people don't want to employ somebody if they've had depression or have a lot of anxiety. So I think in primary care, it doesn't matter if we just assume the two conditions are intertwined, they're connected, in other words, and then we get on with doing something about it. The key thing is, in my setting, is half the patients who turn up with what I call distress, half of them don't come back. So you've really got to get some treatment going straight away at the first visit if you've got time. And I understand in some of your clinics, you have very little time with patients. And that's difficult because mental health care does take a little bit of time. But there are some quick things you can do. As I say, difficult, no need for a label in primary care or a diagnosis. When I use the word label, I mean diagnosis, which is going to be difficult if you've got a medical training, because you're going to think, well, I've been trained how to make a diagnosis. I should make a diagnosis. But unless you need one for official purposes, then I would avoid it. I say to my patients, I don't give labels. I sometimes write that people are stuck, which in English, that's S-T-U-C-K, stuck, because that's how people feel. They feel stuck. And of course, the issue of stigma and shame. This is from a New Zealand study done in 2003. And it's interesting, what they did was survey people from a primary care waiting room. And this is the most, you may think this is old data, but this actually is, there's not been done since 2003. So it's almost 20 years old. But what it shows there is 20% of patients have anxiety in the previous year. 18% have depression. So anxiety is the most common so-called mental disorder. And then there's the issue of substance abuse. And I appreciate that will be different in Yemen. In our society, it's a problem with alcohol, cannabis, marijuana, and more recently methamphetamine, which is cocaine-like substances, and a few other things as well, like ecstasy. So they're sort of, they can become problems. And they become problems when people get distressed because their consumption increases. If the consumption was limited, it wouldn't be a great problem. But of course, when people get distressed, they increase their substances because it's a nice escape from how they're feeling, and people want to escape those feelings. I've had this translated. I may be able to email this to Dr. Hassan. I'm not sure how I can get this to the audience, but I got this translated by one of your colleagues. This is the David Burns Mood and Anxiety Questionnaire being translated into Arabic. This means patient sad or down in the dumps, not at all, somewhat, moderately, a lot, extremely. And each one of these gets a score of 0, 1, 2, 3, 4. What I like about this is that it's fairly easy to ask verbally. I sometimes, we're doing a lot more telephone conversations at the moment, consultations. And this is quite an easy one to do by telephone. It's relatively short and quite easy to ask. Some questionnaires are difficult. And then the score adds up to out of 20. And there's a similar one, for anxiety or worrying. So the first one I say is about to patients, I want to ask you about your mood. How is your mood today? And this one is about how much you're worrying today. Are you anxious? Are you frightened? Are you worrying about things? Are you tense or on edge? Are you nervous? And if patients can't read, it's relatively easy to say, or if they need glasses to read and they haven't got them, which happens in our setting. And these have been validated, and this is what a score means. So a score of 0 means no symptoms, 1 to 2 a borderline problem, 3 to 5 moderate, 6 to 10 mild, 6 to 10 moderate, 11 to 15 severe, 16 to 20 extreme. You really only need to do one or the other in primary care. If you're only going to do one, do the depression one first. The advantage with these is that it gives you a score by which you can then monitor the patient over a period of time. And if they're not getting better, that's when you might want to think about medication. So I'm going to give you an example of a patient. I hope this would make sense in your context. So this is a 30-year-old man. He's a carpenter, and he lost his job 6 weeks ago. There's been trouble in the economy. COVID's affected a lot of jobs. He's got a wife and children, and he's worrying a lot about what he's going to do to pay his bills. He's spending time in bed during the day, and the risk of spending time in bed during the day is that you may nap or have short, that's nap, N-A-P. You might have, you may fall asleep, but then when nighttime comes, you don't have sleep pressure. You can't get to sleep. So having little naps during the day, different from a siesta. Siestas are fine because they're planned and they're part of the culture. A nap can be problematic, particularly if it's after, say, 3 o'clock in the afternoon. That can be quite a problem. So he's not sleeping well at night, and he won't see his friends or family. So he's avoiding people. So he's got sleep problems. His energy's low. He's not got the energy to keep looking for jobs. And he has some physical symptoms with no clear cause. For example, he's got a headache, and he's increased his use of cat or quat. I'm not sure quite how to pronounce that, but you'll know what I mean. That's a substance I understand is used in the Yemen. On its own, I don't know very much about it, but occasional substance use, so long as it's not affecting your life, isn't particularly bad for your health. But what happens when people get distressed is they start using lots of it as an escape mechanism. And so they're not doing other things that are helpful for them. So in my society, somebody would increase their alcohol and there are health consequences on that. People get intoxicated, they get drunk, and they start missing work, getting into trouble with the law. There's a whole lot of things that happen. He has a lot of mental symptoms. When men lose their work, they feel worthless. He feels guilty because he's not providing for his family. He's got excessive worry. He's having trouble making decisions. His concentration isn't good. He's having some suicidal thoughts. And suicidal thoughts are very common when your mood is low. I often say to people, that would make complete sense. In fact, one way of saying to somebody, they've come to see you and talk about it, you can say to them, there's part of you that doesn't want to kill yourself, and that's the part I would like to work with. So that's a nice little saying that gets around the suicidal thought. He's not doing his normal activities. So he's not doing things around the house that he would normally do. So there are two questions on depression. Have you been feeling depressed, down, or hopeless for 2 or more weeks? And have you had reduced interest or pleasure from activities? Now, what's nice about those questions is that in depressed people, they're almost always positive. So if they answer no to those questions, then you can rule out depression. So if somebody says, I'm very tired, I haven't got very much energy, you ask them if they're depressed, they say no. If you ask have they had a reduced interest or pleasure from all or most activities and they say no, then you might want to look at a physical cause, check their blood count, check their thyroid, check their kidneys, whatever you can. Much more likely to be a physical problem than a mental health problem or an emotional problem. So this is, and we did his Burns depression and anxiety score, and he scored 14, which is in the severe range. And on the anxiety score, he got 9. That's a fairly typical pattern for somebody who's got low mood and demotivated. And this is the sort of common pattern you'll see in primary care. You virtually never see somebody with a very high depression score and nothing on anxiety, or a very high anxiety score and nothing on depression. The two go hand in hand. So what are the causes of depression? Well, at one level, we don't really know. There's clearly a social component, because when people get distressed and lose their jobs, particularly for men without work are not happy patients. Work is very important to men in terms of their self-image. There can be psychological things if you're in constant danger, if there's a war going on, which I understand there is in Yemen, if you're being bullied at work or school, they are psychological pressures. If you're working in an organization where you're not treated very well. And then there's a biological component, because we know from twin studies where they look at identical twins who are brought up separately that there is a connection. And things like bipolar disorder are very obviously biological. It tends to run in families. And so those are the three things. Doesn't particularly help us with the patient in front of us, because we may not be able to do very much about their biology or their social situation. We may be able to do something about their psychological situation. The other causes are, of course, war, employment, housing and substances, psychological stress, social isolation, home violence, and biological, family history of depression or anxiety. it's worth, and of course you don't know if this man's mother or father had been depressed. You don't know whether the man has learnt that or whether he's inherited it. From the public health point of view, this is now a priority. There are very high prevalence rates worldwide. There are at least 322 million people who suffer from depression. On average, it's 4.4% of the community. It's up to 20% of primary care attenders. So the patients you're seeing on a regular basis will be, a lot of them will be having 1 in 5 at least, and it may be higher with COVID. COVID's had a real effect on, and another group to think about is women after having babies. It's about 10% worldwide. And some of the New Zealand data would say there are different women. That 10% is a fairly constant figure, but there are some women who get depressed in the first 6 weeks and then get better, and some women who aren't depressed in the first 6 weeks who become depressed. And some men, certainly in New Zealand, become depressed, get postpartum depression. And I suspect that's because they suddenly realize they've got new responsibilities. Disability and mortality. Depression is a major cause of disability. By 2030, it's going to be the #1 health burden in terms of disability adjusted years. So that's low. It doesn't kill people other than by suicide. There is a huge economic and social cost to depression. And suicide rates do seem to be going up internationally. They've been going up in New Zealand continuously. That seems to be a pattern throughout the world. We have an issue here with our Indigenous people. Young Maori men kill themselves. Maori spelled M-A-O-R-I. Kill themselves at a much greater rate. They have a lot of unemployment, poor educational opportunities, poor literacy. So that's one group that really, really suffers. There's a huge impact on families. If a mother gets a postpartum depression or anxiety, it affects the infant growth. It can affect family relations, and I'm going to talk about a case of a woman, and it will affect child rearing. Children who grow up in a household with depression are more likely to have issues with that. There's an issue of wealth and social impact. People who are depressed find it hard to get a job and keep a job. That then causes worsening of living conditions, and it also makes physical health worse. So if you're dealing with somebody with ongoing pain, persistent pain, they quite frequently get depressed. And so you have to deal with the mood as well as the pain. Very hard to sort out the pain in somebody. There's some neurological basis for this. The pain centers and the emotion centers are very close in the brain or in the mind. Here's some figures of association of depression amongst people with physical diseases. So for tuberculosis, it's over 40%. For HIV/AIDS, it's over 40%. For cancer, it's in over 30%, even for simple things like hypertension. Diabetes, not uncommon. That's probably a conservative. People often feel badly that they've got diabetes, certainly in our community. particularly if they've tried to live a good, healthy life. Sometimes your genetics catch up with you. I had an Indian woman in my office, aged 33, who'd been keeping fit and watching her weight, but most of her relatives have had diabetes. And so she was rather horrified at age 33, having lived a very fit, active life, to have got diabetes. Of course, she's managed to control it very well, but she still, at 33, has lost half her pancreatic function. By the time you get diagnosed with diabetes, you've lost half your pancreatic function. So that was, she was sort of upset and grieving, had some sadness for that. And myocardial infarction, over 20%. So the two are very much entwined. And I think that's one of the joys of primary care, is that we get to deal with not just the physical illness, but we get to deal with the social and psychological illness. And that's what I find very enjoyable about primary care. Now, I realize that may be tough in the Yemen if you've got very few doctors and lots of patients. It must be hard to focus on the psychological and the social. Okay, so what to do with this man? Excuse me. I think the key thing is to show some understanding and use empathy if you can. And I hope that's empathy spelt correctly in Arabic. I use Google Translate. You might want to ask about his suicidal plans. Does he have suicidal plans? If he does, if he has plans, then you may need to activate whatever services you have access to deal with that. If not, then you need to alert his family so that they can keep a very close eye on him and make sure there are no weapons or methods by which he can harm himself, such as guns or knives or swords or rope. Of course, that can be very, very difficult. You need to be able to explain, the two key things are to explain what I call avoidance activities and escape activities. And avoidance activities are not seeing your friends and family. And escape activities are spending time in bed when you're not asleep. So this man had taken to his bed and he'd increased his substances with his quat use. And so that's what I'd call escape activities. And the key thing for you with behavioral activation is to reverse those things. Reverse his avoidance and reverse escape activities. That's the role of us as primary care doctors. And I'll show you some of the evidence for that. So his avoidance, you need to point out that not seeing his friends and not seeing his family and not going outside is not good for him. He needs to expand his world. I often say to patients, your world has shrunk down. My role is to expand it up and get you doing things and seeing people. And his escape activities are, we need to reverse his quat use as well as his staying in bed. Those are the escape activities. So I say to people, we are day-night animals. We need to be asleep at night and awake during the day. If you go to bed during the day, you'll confuse your brain. And then you'll start. We see young men on computers here staying up all night and sleeping all day, and they get into terrible psychological states. Very important to be awake during the daytime and asleep at nighttime. Sleep is very important. Should we think about medication? I would say no. I would suggest behavioral activation first. The best treatment, the most effective treatment is behavioral activation. And I'm embarrassed to say I only learned that about 2 years ago, and I've been practicing medicine for 40 years. I work with a psychologist in Amsterdam in the Netherlands, and he sent me a review paper on activation, actually done by David Eckers, who's in the UK, actually a nurse by training. He got into behavioral activation and is sort of a world expert on it. That's Ekers, David Eckers. So this is what I call the truth about antidepressants. So this is based on all the studies submitted to the FDA. Now, these studies are done in generally wealthy, developed countries. So we're not sure how generalizable they are. But this is severity of depression along the x-axis, severity. And then on the y-axis is reduction in mood score. And so what's important about this information is there's no publication bias. You'll be aware that what drug companies often do is do 10 studies and publish the 2 positive ones and don't do anything with the 8 negative ones. This data is everything that's been registered. So to get a medication registered in the United States, where you can make lots of money out of the drugs, you have to have it registered. So these days, pharmaceutical companies all register the studies. This is about 250 randomized controlled trials. So this is the drug effect, and this is the placebo effect. And interestingly, this is what the drug effect is like. If this was high blood pressure, this would be the curve you would get for treating high blood pressure. If this was cholesterol down here, this would be what you would get for giving a cholesterol lowering pill. It's actually a model for most of the drug treatments we give people. The more severe the illness, the more benefit the patient will get. The less severe. So there's not much benefit up here. There's more benefit down here. And I'll show you how much benefit there is. So here's the problem. Okay, I'm from primary care, and this is my worldview. I have some patients down here, but if I was a psychiatrist, this would be the worldview I would see: people with severe persisting depression. And I might say, well, antidepressants are wonderful. They seem to be very effective up here. And then I come along and say, well, I'm from general practice or primary care. They don't seem to be very effective up here. And what happens in our practice is that people get put on antidepressants. They don't get any better. They don't want to stop them because they're worried they'll feel worse. As if they could feel worse. They're feeling about as bad as they could do. So it's a bit of a trap, and they can be difficult to stop. People get side effects. Here's the next thing. So this is what happens in primary care. Visit 1, people might be down at the severe end. But if you show empathy to people, understanding, and give them hope, giving them hope is really important in primary care. And I appreciate that may be very, very hard in your setting if you've only got a few minutes per patient. But if you can, try and give them some hope that they will get better if they follow your advice. Visit 2, visit 3. So you can see any benefit from antidepressants is dropping with subsequent visits. And we know in New Zealand, 85% of people who start up here end up here over the year. 15% of people stay down here, and they're the ones who benefit from psychological therapies like cognitive behavioral therapy and antidepressants. But here's the key thing. The effect size down here is 25%. This is for very severe extreme depression. The placebo rate is 41% at all points across here. So most of the response people get is placebo. So most people who feel better on an antidepressant will in fact have a placebo response, which is why when life starts getting tough again, they start feeling depressed again. They think the antidepressant isn't working, but it probably never worked in the first place, because placebo is a very powerful tool. Up here, this is severe depression. This is mild to moderate. So really, it's only in the very severe. And I was part of the Cochrane review, which looked at antidepressants in primary care. Interestingly, almost all the studies there were in severe or very severe patients. And it looked like antidepressants were very effective in primary care. However, the pharmaceutical companies clearly knew they needed severe patients, and so they studied severe patients, because this is your primary care population up here. I understand fluoxetine is available in the Yemen. So this is from the Soprani review in the Lancet a few years ago, 2018. Fluoxetine is as good as anything else. So these are the SSRIs. Interestingly, the most effective is old-fashioned amitriptyline. But of course, I think that is available in the Yemen. It does have a risk of overdose, of killing people in overdose. So we tend not to use it. But it is a very good second or third choice if the first choice one doesn't work. But there really is no difference between the so-called best one and the worst one. These, what we call confidence intervals, overlap. So there's really no difference between that and that. And this just talks about effectiveness, not in terms of acceptability or tolerability. Okay, so here's the batting order. Now, this doesn't come from one big study. This comes from me putting together all the information. Here we've got the most effective treatment is behavioral activation. 42% of people are better at 2 weeks with behavioral activation, and that is sustained. Now, most primary care people don't know that, and most psychiatrists don't know that. Placebo is pretty good, 41%. That's what we're doing most of the time. CBT is about 28%. Antidepressants at their best in the very severe are 25%, 9% in the moderate to severe, and 6% in the mild. Interestingly, a phone call from a nurse, even over 6 months, has an effect size of 20%. And it doesn't have to be a nurse. It's been done with admin people, telephoning people, and just short phone calls saying, how are you doing? Are you doing your exercise? Are you taking your medication? A few little things like that make quite a difference. A little 5-minute phone call at the most, even shorter. You may have people in your clinics who can do that and keep with people. So behavioral activation, it doesn't take long to do. So you say to patients, who's a good friend that you could get in touch with? And they'll give you the name. Give me the name of somebody, and I'd like you to contact them. Now, what I do here is ask people on a scale of 1 to 10 how likely they are to do that. So if they say, it's my friend Mohammed, I haven't seen him for 2 months, I would say, okay, what are you going to do with him? I'm going to give him a telephone call and arrange to have a meal or a coffee somewhere. So I would then say, how likely are you to do that? And if he, out of 10, if 10 means you'll absolutely do it, and 1 means you won't do it at all, they've got to give me a 7 or more out of 10, because then I know they'll probably do it. Because if they give me a 2 out of 10, they won't do it. Do something pleasurable. What are things you like doing? Try and get them to do some movement, some form of exercise, even if it's just going outside into the sunshine. Sunshine is good for mood. Don't wear sunglasses, let the sun get on your retina. You want to get this man out of bed, and I would ask him to stop or reduce his cat taking. And I usually say to people, I don't have a moral issue with substances, it's more a health issue. And what you're not doing when you're consuming substances. That's the important thing. It's what you're not doing that is important. And in my setting, we've done a randomized trial in my clinic, which is going to be published in the next few months. 50%, 45% of people are better in an intervention group, 25% in a control group, 20% in a control group. So that's a 25% effect size at 1 week. And I'm sure in your setting that would be the case too. It's about as long as it takes to write a prescription or give people medication. Doesn't have to be long. Ideally, I'd like to see somebody a week later. That may be a luxury in your setting, but see them as soon as you can or make contact with them. If you've got a mobile phone contact, that would be, or you've got landlines, then I would do that. You can do the burn score. You can do it by telephone. They're likely to be better the next week somewhat. However, if over a period of weeks or months the score stays up around the 14, then you might want to have a discussion with your patient about whether they would want to try medication. I'm not sure whether cognitive behavioral therapy is available. That also would be good. Cognitive behavioral therapy is as good as medication, but it continues after you've finished therapy because you've trained people to think differently. They've learned a different way of thinking. They need, and yeah. Okay, so the second case is a 21-year-old woman. She's got a baby son aged 2 months. Her husband works 200 kilometers away. He comes home once a month when he can. She lives with his sister. It's not a very happy setup. Her Burns depression score is 5, but her anxiety level is 14, which is in the moderate range. And we would say she is vigilant or hyper-vigilant. She's overly worried about this baby. But she's not a postpartum depression. It's more a postpartum anxiety. She's reluctant to go outside in case the baby catches illness, maybe catch COVID. She washes her hands a lot to keep the baby safe, and she's not contacting her friends. So what do we do in this situation? We show understanding and we use empathy. Empathy is important. Hopefully that's correctly spelt in Arabic. Now, one very nice thing you can do with mothers in this situation, and we've got a nurse in our clinic who does a lot of this, is to rephrase or reframe her concerns, that all this worrying is her trying to be the best mother in the world. So actually it says some good things about her. We could say, oh, she's just a very anxious new mum. Or we could say, well, actually, she wants to be the best mother in the world. And if you were on the receiving end of that comment, wouldn't you rather be told that you were wanting to be the best mother or parent in the world rather than you've got a moderate to severe anxiety condition? You'd explain to her her avoidance activities. The thing for anxiety, so behavioral activation for depression, also for anxiety, but exposure is what people need. And you have to ask her, would she be willing to try these things? I would use the word, would you be willing to experiment with these things? I'm not sure if that's a word that would translate very well into Arabic. So encourage her to wash her hands less often, to contact her friends. And most women have 1 or 2 close, intimate friends. So you could say, who's a close, intimate friend? And she would say a name, and you would say, okay, it would be good if you could contact her. What could you do with her? And she might come up. So you let her lead. You give her, you don't tell her what to do. You try and encourage her to come up with some solutions, because then she'll take responsibility for herself. You would encourage her to go outside and say that the risk of COVID is very limited if she wears a mask. If the baby were to catch COVID, it probably wouldn't do it any harm. With her at age 21, probably won't do her too much harm as well. But I don't know how easy it is to wear masks or face coverings is another thing, just putting a shawl around your face. To consider going out walking, and perhaps to see if her sister-in-law would look after the baby so she could have a bit of a break. My two daughters have had babies in the last few years, and it's made me realize how tough it has been a parent. I seem to have forgotten about it, basically. But now that I'm a grandfather, I'm starting to understand these things a lot better. So follow up. She's likely to be better at the next visit. If not, consider referral. You might want to consider medication if she's not making any progress. You might want to get a support agency. I'm not sure what resources you have, but I always feel it's a bit of an emergency when a newborn mum is struggling. It's very, very tough time biologically, psychologically, and physically. It's a very, very tough time. And I think we need to give them all the support because that first 1,000 days from conception to 2.5 is crucial for the child's development. So if you want that child to grow up healthy and happy, then you have to help the mother become healthy and happy. Okay, so to summarize what I've talked about, depression, anxiety, and there's a move amongst diagnosticians to call it mixed anxiety and depression. I personally don't think that's an improvement. They're common in primary care. COVID has probably made things worse. The other things that's made things worse in New Zealand, we've had a 13% rise in Maori and Pacific girls, teenage girls, and their depressive symptoms. And that's thought to be due to social media. So I don't know quite what effect social media is having in Yemen, but it seems to be, that's over 7 years in New Zealand. It's an increase, like 2% increase per year of depressive symptoms. Very scary. And that may be happening everywhere. No need for a diagnosis, but start some treatment at the first visit, and you can do non-drug treatment. If you don't have access to drugs, it's actually better. I think in countries like New Zealand and the UK, where Dr. Hassan works, I think the access to antidepressants actually does not necessarily benefit our patients. They get onto them way, way too quickly. Behavioral activation first, consider medication later if they're not showing improvement, and that's why doing the questionnaires are quite good, and follow up where and when you can. That's the end of my talk. Thank you very much.
Well, thank you. Thank you, Professor Arrell. We're getting a lot of compliments in the question and answers. So I won't, it was such a packed talk. I won't aim to summarize it in any way or form. But thank you also, Professor Arrell, for translating parts of it into Arabic, and to make it relevant for the Yemeni participants. The behavioral activation was introduced to. Some of us may have heard it for the first time, but perhaps taf'il suluk and the use of empathy, ta'atuf, and tafahum, understanding as well, and then avoiding those things that people keep away from, the haribat, and which they avoid, the tajannubat. So we've got a few questions. Professor, are you happy to take them?
I am.
And just to emphasize that at least well, half of the participants seem to be complimenting you here as well. So thank you again. It's a wonderful thing when we're able to support our Yemeni colleagues from both sides of the world, the other sides of the world, from New Zealand and the UK, and I can see there's been help and otherwise from the other parts of the Middle East and Australia and South Africa. But first question is, mental health is often forgotten in the Yemen. How can we make mental health more important for our in our own practice amongst doctors and policymakers in the Yemeni government, for example, the Ministry of Health? So it's a more societal question.
It is. Well, it was interesting. We just ran a conference here in New Zealand, and I was interviewing a man called Sir John Kirwan. He's a very famous rugby player. You may never have heard of him. I realize rugby's not a big game outside of a few countries, but he suffered from depression, and he talked about that in public. He's famous in New Zealand for talking about his depression. And he says he starts every day with doing something for his mental health, a bit like keeping physically fit, emotionally fit, watching our weight. I think we need to live it ourselves. And I'm not sure how much political power doctors have in the Yemen, but it's certainly, we know mental health issues are becoming, and as I showed you there, by 2030, depression is going to become the leading cause of disability in the world, and that's in all countries. So it's important not to forget mental health because, it affects our physical health. And I think maybe we have to get more political about it. I'm not sure. I imagine the audience probably have more solutions than I can come up with.
Right, and so let's do that. In terms of if there's suggestions from Yemeni participants, otherwise, please do put them forward. And that's the benefit of a conference of this type, and perhaps we can further in the future talk about a conference specifically just for mental health issues.
Count me in. Count me in.
Brilliant. A question: how would you use this information looking after children? Is there anything specific with regards to younger people, adolescents, for example, with depression, anxiety?
Well, the interesting thing in most countries, that is the peak. In New Zealand, there's an enormous peak from about 15 to 25. I think a lot of young people think it's older people who get depressed, but actually older people are happier. There was just a thing in The Economist this week about it, actually. So there's a lot of, and I think education of young people is quite important. How to deal with social media. In fact, Sir John Kirwan suggested that young people don't use social media as their way of finding out about the world, because things like Facebook and those things, they're trying to get your attention and they want to shock you. And that gets young people's attention. So their view of the world becomes much more negative than it needs to be, really. So I don't know how that translates into life in Yemen. But I think I spend a lot of time educating young people about their fears. Anxiety is probably more of a problem in teenagers, but they have a lot of negative. I work a little bit with a chap called Paul Gilbert in the UK, in Derby, and he's interested in compassion, self-compassion. And I often talk to young people about the emotional tone of the conversation in their head. In their brains, they say terrible things to themselves. And that, of course, if you have negative thoughts, that will translate into negative emotions. That's why we do cognitive behavior therapy, to deal with the thoughts, to deal with the mood. So there's a lot. I mean, it's a very tough time being a teenager. You're becoming an adult. Your body's changing. There may not be much future for you. A lot of stresses. I think easy to underestimate the stresses on young people.
Thank you. You mentioned a little bit about Sir John Kerwin and increasing the emphasis of depression amongst society. There's a question in regards to shame and stigma. Many young people aren't happy to talk about mental health issues. How can this be alleviated? How can this be alleviated by the doctor and in general?
Yeah, I think asking young people. We have a project in New Zealand where children at about 15 or 16 are all screened for mental health. Just asking them to say, if you've got a bit of time, to say, we routinely like to ask people about their mental health. How are things going for you at the moment? And if they come back and say, well, things are a bit average, that usually means they aren't going very well. I ask people, I have a question. I ask, what's your emotion? I'm just getting this published at the moment. What's your emotional quality of life if 100's perfect and 0's worst imaginable, and anything below 50 is associated with a low mood? It's very specific. It's not very sensitive, very specific. And so that in 15 seconds will give me a feel. So anything below 50, I'm then wanting to know more about what's going on. I tend to only see children when they're brought in by their parents, but I do a lot of education with the children, learning how to deal with their negative. And one of the sentences I say to people is explain to children that their brain is designed to keep them alive. It's not there to make them happy. And there's no delete button. We can't get rid of thoughts in our mind. We need to hold them lightly. And I get them to cup their hands like this and hold that feeling lightly and just experience it. They want the feelings to go away, but training your mind to experience uncomfortable thoughts and feelings is essential to living with ease. And as adults, we gradually learn how to do that. But when we're teenagers, we just fight with those things. We just want to make it go away. I use the analogy of a football. If you're standing in the water, you're trying to push it down. The harder you push, the harder it bounces back up again, or a beach ball or whatever. So that's what young people are trying to do. Push their feelings away and they just bounce back up again. And they just keep doing that and doing it and doing it and getting nowhere. So learning to give up that struggle and do something different is quite important. And the other thing, as Dr. Hassan made the comment, mentioned, I do acceptance and commitment therapy. The basis of acceptance and commitment therapy is that avoidance is the source of human suffering. When we avoid things, we get ourselves into trouble. So avoidance is what we've got to stop people. And you will see me there reversing the avoidance, reversing the escapes that people try and do. And that's learning to live with ease. We can't live without suffering. Suffering is part of being human. We have to learn to live with ease and accept some of the suffering.
Thank you. There's a few questions with regards to specifically dealing with intrusive suicidal thoughts. Are there any specific means that a doctor can use with regards to dealing with such thoughts, or anything in particular that you found that is particularly helpful?
Well, in my setting, suicidal thoughts are very common. About 6% of my patients will have suicidal thoughts. Suicidal acts are very rare. About 1 in every 200 people I see will actually have a suicidal act. It's very, very hard in primary care to do anything about that. I think we need to ask about it. And do they have any plans? Any plans is not a good sign. I don't know what resources you've got in Yemen to deal with that. We would put somebody in hospital who had suicidal plans. And if they've got no protective factors, that's the key thing. Like, who would be upset if you died? If they said nobody, if they can't find somebody that would be upset. Um, and I also use that thing of Russ Harris, who's an ACT therapist, is there's part of you that doesn't want to kill yourself, and that's the bit I'd like to work with, because you've got to get people moving and doing things and getting on with their life and giving them some hope. So, and to say to somebody, well, if I was feeling like you, I'd probably want to kill myself as well. But one of my colleagues says to people, and I don't know, I don't use this very often, that's a permanent solution for a temporary problem. And that may sound a little bit simplifying things a bit, but there are no winners when somebody commits suicide. The doctor isn't better off, the patient isn't better off, and the family isn't better off. It's a disaster all around, but it does happen, and it's young people in our society and some older people, predominantly younger people.
Great. There's a question regards follow-up appointments and how you structure them. Do you leave them in the hands of the patient? Do you leave them, or do you arrange the follow-up appointments?
I always arrange a follow-up appointment unless we agree not to meet. And I always say the door is open. I think it's time we finished, but you're welcome to come back anytime. The door is open. I always make an appointment because we use a computer screen, because if they don't turn up, then I might want to phone them up and see what's happening. Sometimes they cancel the appointment, I don't notice. But I will say, well, would you like to catch up? When can we make an appointment? And I usually try and put it for a week in advance. I realize that might be a real luxury with the volume you've got in Yemen, but try and see them as soon as possible. If you can't, is there a nurse or a healthcare worker who could contact them? You need to build a system that will do that. You as the doctor can't. Although if you're really worried, I occasionally see people the same day. I'll get them back. If they're deeply suicidal, I get them back the same day. And I have done the occasional house call, literally driven in my car to see somebody who I was very worried about. But clearly that you've got to have the resource. So if you haven't got the resource to that yourself, and you haven't got nurses who can do it, then just another human being. I always say it's sharing the love. Another human being from your clinic phoning up somebody, don't have to be specially trained, somebody who's warm and understanding. Middle-aged women are fabulous at this. In our setting, they feels like your mother's phoning you up or your grandmother's phoning you up. So try and set that up in your clinics if you can. Don't know whether that's possible or not.
A few more questions. The Burns psychiatric screening, is it just as relevant for children as adults?
I don't think it's been validated in children. There may be other questionnaires that are better. Once you get under 12 years old, the whole children's question thing becomes a bit different. But once they're teenagers, I think it's probably fine. Should I email that to you or to Dr. Mubasher?
Perhaps to Dr. Mubasher. I think that's.
Okay.
And what I'll do though is I'll make sure you have my email address.
Okay.
So
Yep.
so cover copying that to me as well. No problem. It will get to the participants. Thank you for that.
I'd love them to have that and see what they think. I found it just very short, simple, and easy to do. Patients don't seem to have any trouble with it. PHQ-9 confuses people.
There's a question about housekeeping. So in the sense of doctors facing, doctors specifically in Yemen facing so many challenges with regards to war, the social circumstances, war, the economic difficulties, and looking after others with mental health issues. But what are the best ways for doctors to maintain their mental health?
Well, I think I'd follow Sir John Curwen's advice and start every day with some little. He has a an app called Menti Mia. It's Italian for good health, I think. Mentemia, and it has teaches you how to breathe. So learning how to breathe slowly, because breathing slowly is important. Just taking a mindful moment to be grateful for being alive, being grateful for being a doctor. Being gratitude is an important thing, I think. Trying to keep physically fit. I don't know how easy that is in Yemen. In my society, we generally have to go to gyms to do that, gymnasiums. But keeping physically fit is it's absolutely essential to me. I have a thing called my dashboard warning light. When I don't want to do exercise, that's a sign that I'm getting stressed. So if you're starting to have avoidances, you don't want to do things, you're not looking forward to going to work, everything's seeming like a hassle, that's a sign that you're starting to burn out. So, and you, in your setting, you've really got to look after yourself because there's a huge number, there aren't a lot of you, and you are a precious resource. And looking after yourself is absolutely important. So your mental health and physical health should be a priority every day. It's always important. And if you don't, I have a little saying I said to one of my staff members the other day, if you can't make time for healthy activities, you'll have to find time for illness. And it's quite a nice little, and she rushed off to the gymnasium, actually, put her gym gear off and went off. But that's quite a nice, yeah, so you have to find time for health. Otherwise, you're going to be facing ill health.
Brilliant, brilliant. Thank you very much. Again, just lots of thanks coming into you, Professor Bruce.
Okay.
Brilliant. I wonder how we're doing for time. I think we'll need to conclude now.
Yep.
There were a few questions here and there, and I wasn't able to give them justice, but I think we got through the bulk of them. And just to reiterate our thanks to yourself in terms of highlighting behavioral activation and really contextualizing the information you gave and the Arabic translation, and hopefully giving us ideas in terms of how we can put this into practice. And certainly when we have our mental health conference, it'd be brilliant to have you back again.
I would love to come back. It's been a real honor and privilege to be invited. So thank you very much for the honor.
Thank you. Take care.
Okay. Bye-bye.
Bye-bye. Thank you. So just to remind everyone, we're in our second day of the INTERYem, the International Network for Training, Education and Research for Yemen conference, with esteemed lecturers from all over the world, aiming to collaboratively support our colleagues in the Yemen, and therefore then support the Yemeni population, especially in light of the difficult circumstances they face. I can see that we've got our next speaker, Dr. Steve Holmes, waiting. So welcome.
Good morning. Thank you.
Good morning, and I suppose it's good afternoon and lunch. So مرحبا بكم يعني المشتركين في اليمن. So and welcome to those who are taking part in the Yemen and others who are participating in other parts of the world. Let me introduce Dr. Steve Holmes. He's been a general practitioner since 1989, and he continues to work clinically. He has had a respiratory interest for the majority of his GP career and involved in medical education and training. He has produced over 300 publications and is on the executive committee of the Primary Care Respiratory Society and has been a previous chair as well. He's been involved in producing various national United Kingdom guidelines and projects with the Royal College of General Practitioners in the UK, specifically, especially in the last decade or so. He works at the regional level, developing GP trainers and supporting doctors in their specialist training program as an associate postgraduate dean. He's developed a variety of quality improvement and leadership courses for GPs and clinicians with a respiratory interest, as well as middle grade managers across the NHS, and has been actively involved in an international program and supporting GP colleagues. Dr. Holmes has undertaken work and support in Southeast Asia, the Middle East, North America, as well as many parts of Europe. And he has interests in obstructive airways disease, asthma, and COPD, as well as COVID. I'd like to invite you, Dr. Holmes, and the title of the talk is Principles of Managing Chronic Respiratory Conditions in Family Medicine. Just to remind everyone, if they carry on being muted, if you don't mind, for the period of the talk, at the end of the talk, there'll be, please submit any questions that you may have. At the end of the talk, there'll be ample opportunity for Dr. Holmes to reply to any questions that you may have. Thank you very much.
Thank you very much again, and it's a real honour to be here today and talking to you. Steve Holmes, I'm going to talk about chronic respiratory conditions rather than acute primarily today. And what I'm going to try to do is give you some hints and things that I hope you can apply in your own clinical context to improve the care of the patients we look after. That's a quick rundown of the sort of roles that I'm doing in the UK and elsewhere, and other sorts of bits of research and other things going on. The main thing that I probably wanted to just touch on is to say we all work in different parts of the world. This is actually my surgery, but usually in the UK it rains a lot. So this was on a good day when we didn't have a lot of rain. But that's a family practice setting in the UK. Can I just first of all thank you for your contribution to the health of your population. I think when we start in our careers, we don't often think about how hard things might get. And often it's not what we set out to do, but we end up working very hard, running 40 kilometers and then doing another 40 kilometers, working on long hours. And I think across the world, we need to try to stick together and we need to try to support each other, because dealing with people who have problems, dealing with, as we heard earlier, with people with severe depression, with long-term conditions, can be very demanding on us as well as our population. And it's important that we look after each other. I guess the core principles of family practice are the same throughout the world, which is one, let's see if we can get the diagnosis right when we see somebody, because that helps us to give appropriate treatment and support to the individual concerned. And it also means that if it doesn't fit in with our pattern of normal disease for those common conditions we see, we can either try to engage specialist care or start thinking again, what else might it be? So the core principles of good clinical care remain the same. I'm going to cover two conditions primarily, one asthma and two COPD. Now, asthma is probably the most chronic long-term condition that can affect people throughout their life. And the picture where it says respiratory health is of somebody called Paula Radcliffe, who has significant asthma, but is the world's, or for many years was the world's fastest female athlete running 40 kilometers. I think one of that message to me is that asthma should not be disabling people. There are lots of professional sports people throughout the world who have asthma and have it controlled. There are lots of people throughout the world who have asthma that is controlled. It shouldn't be a reason to say, well, I can't run because I've got asthma. I'm not allowed to do all sorts of activities. Similarly, a lot of people have a more chronic obstructive pulmonary disease, what we used to call emphysema or chronic bronchitis. And those people with COPD, again, we need to be trying to provide an image of activity and health and what we can do to make a difference, because we can be very positive about these conditions and we can help people to improve the quality of their life, keep them at work, keep them active, and keep them enjoying things. Just wanted to point out one of the groups that I'm working with quite a bit, and one of the groups which is a great source of support for many of us around the world, the International Primary Care Respiratory Group. Lots of different countries involved in this at the moment. The conferences, and there will be a digital one in May, are absolutely superb if you have a bigger interest in respiratory problems coming through the door. And it's a chance to meet up with colleagues from throughout the world and have a chance to chat to them about the care that you're providing and how to juggle round, because often when you see the national and international guidance, it isn't always feasible to think, well, I haven't got all the equipment there. I don't have a fractional exhaled nitric oxide machine or spirometry at hand to be able to do that all the time. We have to try to adapt some of those golden sort of ideals of healthcare into a way that we can do it in real practice. And if you go to the IPCRG website, there are plenty of simple bits of 1 or 2 page advice on how to help people to stop smoking, making a diagnosis, etc., that I hope you'll find useful, but have been developed with a world market in mind. Just worthwhile talking about guidelines because we see a lot of them. And in the United Kingdom, we have a Scottish guideline. We have a Specialist Thoracic Society, BTS guideline, which are quite commonly used. We have an English guideline called the National Institute for Clinical Excellence, but also quite a few people use global guidelines, of which GINA is probably the most widely known. And in actual fact, GINA is a group of experts rather than the big balance group, and they don't do a formal literature review. They select the literature they wish to use in their updates. But all these 3 are quite widely used, certainly in the UK and in many parts of the country, the world. But remember, wherever you see your guidelines, it isn't just the guideline that helps us. It is what our patients want from the experience and what is available to them. The guideline or the evidence base is that science, but also our clinical experience in that scenario, in that meeting with our patients, makes a big difference. So we do have to not only treat according to guidelines, but according to what our patient wants and according to what our experience is of how well it works in our environment. And I hope many of you will have, or if you haven't, can try to get access to something called a peak flow meter. One of the interesting things I find in the United Kingdom is this is a simple measure to check how efficiently people can blow air out of their lungs. And what people need to do is set the machine to 0, take the biggest breath in they possibly can, blow out as fast as they possibly can, repeat that 3 times, and the results should be very close to each other with the best result. Unfortunately, in the United Kingdom, and I'm sure it's true throughout the world, a lot of people don't take in the biggest breath. They take in quite a big breath, and they don't blow out as fast as they possibly can. They blow out quickly, but that in itself is variable, and it's not showing what the peak flow rate is, the peak amount of air that somebody can blow out. So if we're going to do a test, it really has to be an accurate test. The same is exactly the same if you have a spirometer in your practice and are undertaking spirometry. You have to have the technique right, because this is an effort-related test. It isn't just something that you're taking a blood sample and you can look at it, or if they're in the right position, you can get your chest X-ray done. And it's important because we are clinicians and we don't often have the tests that perhaps some of our specialist colleagues do to look at what these tests on their own mean. And you will hear colleagues talking about, oh, well, I've done spirometry and that says they have asthma. Or I've got quite a change in their peak flow, that must tell us they have asthma. And some of the more specialized units now using fractional exhaled nitric oxide or measuring blood eosinophil counts. But sensitivity, it means the test is positive. Does that mean they have asthma? And from this review of the literature, and there's been several that show identical results, the literature is the same. What we know is even if you have positive spirometry or positive peak flow variability, that does not always mean the diagnosis correct. We have to use our clinical judgment. And that is good if we are in an environment where we don't have access to tests easily, because we then get into a situation where we are trying to measure whether somebody has asthma. Let's just think that through. And I'm going to talk about high probability, intermediate, and low probability. If I think somebody is very likely to have asthma, they will often have a family history. They will have history of variability of symptoms that come and go at different times. They will often find that they have wheezing at night, wheezing when they exert themselves, symptoms often worse with coughs, colds, sometimes with if they're in smoky environments or if they're in stressful situations. And if I've got that sort of good history and I can hear a prolonged expiratory wheeze in the lungs as well, that's making me much more likely to think this is going to be asthma. If I can do a peak flow reading, then in the UK, I would code that as suspected asthma. If you're not using a computerized system, put down query asthma. And ideally, because asthma is inflammatory, I would use an inhaled corticosteroid for about 6 weeks to see how they get on. And I would ask them to come back in 6 weeks when, if they had improved a great deal, I could make the diagnosis. A couple of things on that. How would I assess that objectively? I could do that with a peak flow in my surgery the first time and when they come back and show that it's better. I can also do that with something called an asthma control test, which is 5 or 6 questions, validated in most parts of the world, available for children too, the children's asthma control test, that will help to determine whether somebody has symptoms and how well they're doing. If I've seen somebody with asthma and I've tried a course of treatment, and I mentioned inhaled corticosteroids, but if it is oral steroids only when they are in an acute situation, I would expect a good response fairly quickly. And when they come back, often my patients will say, this is the best I've felt for months and months and months. Brilliant, thank you very much. If we're getting that, we've got a good response, we've got the diagnosis. If we haven't, we need to think again. And that's where potentially we move into more testing, where we might think about spirometry with reversibility. We might think about blood tests for eosinophils and other sorts of tests, skin prick testing, if you have them available. I suspect, certainly in the UK at the moment, most practices don't have fractional exhaled nitric oxide. A few are getting that now, and most of our hospitals have access to that, but it depends on what is available. And also in general practice, in family practice, we are able to observe people over a period of time to see how things develop. The final one that went into guidance is if it isn't asthma, please don't treat it as asthma, work out what it is in some other way. And I think you've got to put that into a guidance, but actually we know that ourselves being active clinicians. Important just to think through, if we are thinking about asthma, there are a lot of other conditions that might mimic asthma. Persisting cough, think about pertussis. Obviously acute coughs, we're familiar with COVID, with pneumonias, with bronchitises. But chronic cough symptoms linked into gastroesophageal reflux wouldn't be uncommon. In older people, we should be thinking cardiac issues potentially as well. And quite a lot of people who are young, the prevalence in young people of inducible laryngeal obstruction is as common as asthma. An inducible laryngeal obstruction is an inspiratory noise rather than the prolonged expiratory noise you hear, and is usually much more short lasting. Just as a word of warning as well, COPD in younger people is quite well recognized and can mimic asthma. And one of the key things that the European Respiratory Society identified was the shisha pipes, the water pipes where we bubble the nicotine and smoke through the pipes. Actually, one pipe is the equivalent to 100 to 200 cigarettes. And when I've spoken to colleagues in other parts of the Middle East and in Southeast Asia, they suddenly say, that probably explains why I see quite a few quite young women now with very severe COPD. And it's because they're smoking these shisha pipes thinking they're safer than the sticks, the normal cigarettes. But we have to keep thinking. Another quick tip is if you see an adult coming in with new symptoms, a significant number, about 1 in 6, it will be linked into either their hobbies, but often their occupation. And in the UK, that's often where we would go to try to engage a specialist, because trying to disentangle exactly what the cause is important. If you develop occupational asthma linked into one of the many food problems or chemicals that you're involved with, if you are removed from the trigger that is precipitating your asthma, that is making you get asthma, you will prevent the condition from persisting. If you stay in that environment for a year or so, your condition, your asthma will stay with you long term. So important if you're seeing people early on to think, is this linked into their job? And notice their healthcare workers can link in with that. And that's often linked into latex or linked into some of the chemicals people use within hospital settings for endoscopies and things like that, cleansing fluids. As family doctors, we deal with people of all ages. And again, it's quite common to see children under the age of 5. And some of these children can get very wheezy at times. I think what I would probably just say as a key tip for children under 5 is most specialists do not diagnose asthma under the age of 5 in the UK, in Europe, in America, in Southeast Asia, and in the Middle East. Genuine clinicians who have a big interest in children's asthma, pediatric respiratory physicians, very rare. And the reason for that is, and I'm going to show you a little bit of data, but if you develop asthma at about the age of 6, only 1 in 5 children grow out of it. But in the younger age group, most children, their pattern of wheezing will change. And this was a study performed quite a few years ago now, back about 12 years ago, looking at children who presented with wheezing. They described 2 types: episodic viral wheeze, a wheeze when the child clearly has a cough and cold, and multiple trigger wheeze, a wheeze when they exert themselves, when they go to bed at night because of a temperature change, when they get stressful, and with coughs and colds. And what the group did was follow up children over a period of time. And what we found was those that had an episodic viral wheeze, many of those just settled down, and some went on to have multiple triggers to their wheezing. The same with a multiple trigger wheeze. Many of those, and multiple trigger wheeze sounds much more like asthma. But quite a lot of those went on to have just episodic viral wheeze, and many still settled completely again. So that's why specialist doctors tend not to make a diagnosis of asthma under the age of 5. And obviously in different societies, having a disease label at a young age, rather than assuming that most of these are going to get better, can have impacts on their choice of career and in terms of their own abilities as they get older, if they're labeled as having asthma. Quick things about episodic viral wheeze: only when you've got a virus, short lasting, usually with no history of eczema or allergic rhinitis. Whereas multiple trigger wheeze is occurring for a variety of reasons, often with cough, often with a family history of asthma, eczema. But I know in real world practice, when we're busy and it's difficult to work out what's going on, it's hard to distinguish between the two. And we sometimes have to vary between which one do I think it is likely to be at the moment. If it's just acute wheezing and it's very mild, we don't need any treatment. If it is more significant, then I would in practice be virtually always using salbutamol via a pressure meter dose inhaler and a spacer device. And if that doesn't make sense to you, if you look on Right Breathe website, you'll see some information on that. I used to use nebulizers about 15 to 20 years ago, but the spacer in children with salbutamol works faster for them and is much more effective at a lower dose of drug. There used to be a phase for using montelukast, a leukotriene receptor antagonist, but more recent reviews have shown that's not particularly effective. And for more severe wheezing, there is good evidence in hospital-based medicine, and there's a good evidence in a primary care setting that a short, sharp course of steroid tablets can help a child and help to avoid hospital admission where it's appropriate. If they have multiple trigger wheeze, then I would move into the treatment along the lines of asthma, but I just wouldn't label it as that because I don't want to leave the child with that label long term when probably for decades, if not the rest of their life, they never have a problem with it. So a bit like trying to develop a jigsaw of an image, we need to put little bits together when we're seeing children and often make that diagnosis at about the age of 6. And when I'm seeing children, I will say, let's see if we start treatment like an inhaled corticosteroid, as we would do in asthma, to prevent the inflammation. We'll reduce the dose if we get very good control, and then we'll try without again to see if the problem has naturally resolved. It's not there forever. Let's think about a review. If I'm seeing somebody back with asthma, or they come in to see me with asthma for the first time, the first thing I try to do is work out, is it really asthma they've got or is it something else? The second thing is, if it is asthma, does this link in with their symptoms link in with their asthma condition, or is it another coexisting condition? And a lot of people, you will see when you manage people with acute asthma, families look very anxious, children can look very anxious. And when you go in and relax, the whole situation can de-escalate quite a lot purely because of your calmness in that environment. But again, is it something else that is causing the symptoms is always on our mind? Think about a structured review. And with that, I'll touch on that in a moment, but also if you can work out what your patient thinks asthma is about, what are their expectations? Do they expect never to be able to run and not to be able to work because they've got asthma? Or are they very worried about potential side effects of the medication, and then share that plan with them? And obviously we always make medical records, our medical notes. And perhaps what we need to be doing is trying to work out what symptoms our patient has. Have they been admitted or have bad exacerbations? If they've got an inhaler, can they use that appropriately? There's no point in using an expensive inhaler if it's available, if they can't actually use it properly. That's wasted money for them, it's wasted healthcare resource. Equally importantly, remember, encourage activity, smoking cessation, vital at all stages, and if you can measure lung function as we move on, that's very useful. Plenty of good evidence that self-management plans, telling people what to do if their symptoms worsen, can help in the long run. And most of the guidance is very similar. There's a slightly new theme from GINA at the moment, where they talk about using a low-dose inhaled corticosteroid as the first line of defense, or a low-dose inhaled corticosteroid, ICS, with a LAMA as required in that early phase. At the moment, if you can get people just using the inhaled corticosteroid, that is cheaper than a combination inhaler, and in many patients will be very good if they can use it regularly. And so that would be the way that I would still be using that in the UK. And I think many countries around the world are sticking with that, unless they have a lot of easy access to very cheap combined inhaler devices. When would I refer to a specialist? If I don't think the diagnosis is right, or I can't control the symptoms with normal levels of medication. I mentioned occupational asthma as a reason for referral. In the UK, if I'd needed to use oral corticosteroids in the last, more than 2 courses of oral corticosteroids in the last year, or they were using lots of their blue inhaler, I would be thinking about referring them. And if they'd ever had a severe or life-threatening episode, they probably should remain under specialist care if they've been ventilated in the acute setting. quick tips on exacerbation management for asthma, and then we'll move on to COPD. Number one, remember with asthma, and this is difficult because I look at quite a few of the cases in the UK of children who die from asthma, because we always have an investigation into those, and I look into those regionally. When I speak to the paramedics, the doctors, the emergency doctors, the intensivists involved, when they talk about a child with asthma, they all say trying to ventilate them is incredibly hard. Really harder than much harder than most adults. And the reason for that is with mild asthma, we start to get tightening of the muscles and we get inflammation in the lining of the bronchiole. And we get slightly more mucus secretion. That's the middle image there. And obviously, if you relax the muscles with a short-acting beta agonist, that will relieve some of the symptoms because it will widen up the airway a fraction. But if the asthma is ongoing and that inflammatory process is continuing, you get more and more thickening of the airways that close up, you get more mucus, and you can't push air in or out. I know of colleagues who have sat up all night in an intensive care unit ventilating a patient because the machine won't push in hard enough to get the air in. That is untreated asthma. That's why we need to use preventative medication, which is steroids, either inhaled corticosteroids, ideally at a low dose on a persistent basis to settle down the underlying inflammation in the airways, or in an acute setting, early corticosteroids to help. I'll whiz through these, but this is just a reminder that an exacerbation of asthma in someone who is on preventive treatment should be a rare event, usually about once every 10 years. And turning up at an emergency department should be an incredibly rare event, usually about once every 50 years. So if you have a patient running in and out regularly, it's worthwhile trying to think about what you're going to do with them. Personalised asthma action plans are very much used in the UK, but they are helpful for somebody with worsening asthma to know how to step up their own treatment and when to call for help. When you have an acute exacerbation, usually people have 2 or 3 days. Asking them to present earlier or to start their treatment earlier is very important. There are definitions of moderate, severe, and life-threatening asthma, and I think that is handy. The acute asthma is usually when you've got a peak flow of 50% or less. You have a respiratory rate of more than 25 and a heart rate of greater than 110. And also that's at the phase where people start to not be able to finish a sentence. So you can hear them when you speak to them on the phone, or you certainly see that in a clinical context. And life-threatening, the bit that scares a lot of us when we probably can't get a peak flow because they're too poorly to do that. Their conscious level is changing. They're getting exhausted. They're developing cardiac arrhythmias, silent chest, really bad news. But that's where we need to get emergency services involved wherever we can. I've summarised that again, and I'll make these slides available so you've got them as a reference, and also so that you can see the links so that you can use those at a later stage when you want to. But if I move on, a few quick tips on asthma management. Please give steroids early. That can mean the difference between life and death. We know that oral prednisolone given early is as effective as intravenous hydrocortisone. So if you want to give oral, that is just as good. But use an adequate dose to make sure it works for the patient. Use of beta agonists, again, very sensible early on. And you can use quite high doses whilst waiting for treatment. Ideally, if you're using a nebulizer, it should be an oxygen-driven nebulizer, but that, again, isn't always possible. Don't treat somebody as being automatically hypoxic. Use that if their saturation levels are low. And another key tip that I see commonly in people with very definite young asthma, often they're given an antibiotic, but They don't need it. Asthma is either triggered by environmental factors or viral factors. For genuine asthma, no need for antibiotics, just prednisolone. For asthma and COPD combined, I might be looking more at an antibiotic then. That's a quick run through on asthma. I'm going to go through COPD a little bit more quickly at the moment, if that's okay, and then we'll get on to questions at the end. Again, GOLD guidance comes out every year. It isn't particularly a guideline, it's a report and a strategy technically, but it is very widely used. There are a variety of other guidelines, and in Britain we tend to use the National Institute for Clinical Excellence guidelines, which fit in with a much more academic process where they do a systematic review, and they have family doctors and specialists and tertiary people and researchers and people involved rather than just tertiary level academics. But let's look at what the guidance says now, because when I started in medicine, people used to say the only effective treatment for COPD, emphysema, chronic bronchitis is to stop smoking. But there is good evidence that if we use steroids for exacerbations or antibiotics, we can make a difference. If we think about immunizations and vaccinations, we can make a difference. Smoking cessation, yes, but also the medications that are increasingly used for COPD are very important, as is pulmonary rehabilitation. And I'll talk a bit about each of those in a moment. So quickly, let's talk about how do you make a good diagnosis of COPD. People to think about are 35 years and over who are smokers or ex-smokers and have symptoms. They would be your target group coming in. And David Price, a general practitioner in Norfolk, who's now working out in Singapore, did a lovely study that showed that people turned up about 6 times to their family doctor with episodes of bronchitis before somebody started thinking about, oh, this might be COPD. Making the diagnosis. Number one, it depends on a good history and examination, 90% smokers or shisha pipe smokers. It also depends on us excluding other things. Ideally, we should have a chest X-ray and full blood count to look for other obvious causes of anemia or for cancers or clear damage, tuberculosis, bronchiectasis, etc. on the X-ray. And it should be confirmed with proper spirometry. Quite a few countries where spirometry isn't readily available have adapted their use to use of just a peak flow meter, and that is contained in the IPCRG, International Primary Care Respiratory Group, guidance on making a diagnosis without spirometry, but with just a peak flow meter. The WHO recommend that everybody has an alpha-1 antitrypsin estimate. Fairly cheap test, but not always readily available. And in some people and in some countries, high-resolution CT scanning is very much part of that diagnosis. But what we're looking for is good history examination, chest X-ray, and trying to show a obstructive picture on spirometry that really helps to confirm the diagnosis. I mentioned shisha pipes as a potential cause. Also, those smoking cannabis and heroin are a much more risky group that tend to develop COPD at a younger age. And in the UK now, if we see somebody coming into hospital in the under 40 age group with significant COPD, we're probably looking mainly at a cause linked to drug use rather than genuine COPD or alpha-1 antitrypsin deficiency. Chest X-rays, quite a lot of chest X-rays and occasionally CT scans suggest hyperexpansion and might fit in with COPD. And it's worthwhile just remembering we cannot or should not make the diagnosis on the X-ray. This is, I've just highlighted the red column here. This is a study we've done persistently in our practice over about 10 years now. And what we have done is if we've had a chest X-ray suggesting COPD, we've gone back and done spirometry on that patient. And in 70% of the cases, it's been normal. In a few cases, we have found COPD, but that's no better than us guessing. So please don't trust a chest X-ray to inform it. There was a rather unusual trial performed where the X-ray request for a patient aged 64 said smoker 20 per day for 40 years, and they had an X-ray, and many of the reports came back saying hyperinflation of lungs suggesting COPD. The same patient went to have an X-ray in a different unit, and the same unit again several months later with the history, needs chest X-ray so that can run in New York Marathon. And they virtually all came back normal. Does show that our radiologists, depending on what we tell them as to how they interpret the picture, but please don't diagnose COPD just on the X-ray. Spirometry, we've touched that already. If we have an older person who hasn't smoked, and most people have, and people talk about biomass fuels, and some people will get that if they're using biomass fuels in the home environment with poor ventilation. But a lot of these people who have never smoked and have genuine fixed low ratio of FEV1, FVC on their spirometry have undertreated asthma. So if you're seeing somebody never smoked, but everything else looks like COPD, think about undertreated asthma. Equally so, this links into interpretation of spirometry, but in a lot of countries, and GOLD recommends using a fixed ratio. If you see somebody very old, completely asymptomatic with an unusual spirometry, you may well be getting a false positive test if their obstructive ratio is down a little bit. In the same way that if you see a very fit young person with an FEV1 FVC ratio in the false negative area, i.e. it's 73, 74%, that would be very unusual. Most people who are young will have significantly higher FEV1 FVC ratios. That's the lower limit of normal compared to just having a fixed throughout life. Big fit person blows out air quickly. Little older person will blow out air much more slowly. Normal range. And we misdiagnose in the younger group and we overtreat in the older group. You might have heard about asthma COPD overlap syndrome, which Gina and Gold brought out a few years ago. They then realized within about 4 months that it wasn't a syndrome because it was two conditions, and syndromes are groups of symptoms. So they tried to get rid of the syndrome part of it. And then most recently, Gold has said, and this is worthwhile just quickly thinking through, we don't refer to asthma COPD overlap anymore. We say that asthma and COPD are different conditions with some common features and common traits. And key thing, if there's any evidence of asthma, then they should treat along the asthma guideline group, which means inhaled corticosteroids. But if they have symptoms, you might want to bronchodilate more. So asthma equals inhaled corticosteroid. COPD means bronchodilate if you can. Equally so they've got rid of the whole syndrome now and say it doesn't exist. But they were the ones that invented it. Interesting. Good. Let's move on to non-drug pharmacological options for COPD. Smoking cessation, very effective, should be able to be done quickly and probably one of the most effective interventions we can. Similarly, availability of pneumococcal influenza and potentially in the future, COVID vaccinations, I'm sure will be part of that armory. Offering pulmonary rehabilitation where it's available is sensible. If it isn't, think of pulmonary rehabilitation as get educated about your condition and get as fit as you possibly can. I'm aware of people who haven't walked for more than about 800 meters for 10 or 12 years, who've been given the diagnosis of COPD, have started working hard and exercising more and have walked up major hills over 7 to 10 miles. It is possible to get fit even with quite poor lungs. Again, have a personalized plan as to what they should do if their symptoms worsen. And as people tend to be older with COPD, it's not uncommon for them to have comorbidities. We need to manage those as well. And these sort of things ideally should be managed at every annual review when we check them through. because quite a few people who smoke and stop for a while, unfortunately, because smoking tobacco dependency is a relapsing condition, may well go back to that. Again, good information on the IPCRG website on effective ways to help people who smoke. What about the pharmacological interventions? Well, nice, try to make it look quite complicated, and I'm going to try and make it a bit easier. This is the nice 4 patterns, forget the 4 patterns, but they're linked into exacerbations or symptomatology. What NICE effectively has said is bronchodilators, a short-acting bronchodilator, the cheap one, Ventolin, is quite handy, but does only last a short period of time. And again, in some healthcare systems, we need to use that. That's our only option, in which case use it. They also talk about long-acting muscarinics, so that will be tiotropium and others in that category, aclidinium, which will both improve the symptoms over a prolonged period of time, but also reduce exacerbations. And they talk about long-acting beta agonists in COPD, which will improve symptoms, but don't on their own reduce exacerbations. If you combine a LAMA and a LABA, you get slightly even more improvement in symptoms than one of them on their own, and slightly increased reduction in the flare-ups, the exacerbations as well. So in some parts of the world now, and in the UK, we're recommended to use a LAMA-LABA combination because it's virtually the same cost in our country as a LAMA, but in many parts of the world, ideally people will be starting on a LAMA. And let's work it through. So in group A, the bottom one, a bronchodilator, the bronchodilator that's going to reduce exacerbations and improve symptoms most will be a LAMA. In group C, it's straight into a LAMA. In group D, it says a LAMA. And in group B, you've got a choice of a LABA or a LAMA, but the LAMA will reduce exacerbations as well as improving symptoms. So that's why probably NICE could make it, GOLD could make it a lot easier and say, just use a LAMA if you have the opportunity. Remember, and again, just to reinforce, if the person has a previous secure diagnosis of asthma, you think it's asthma with substantial variation in peak flare or FEV1, they've got a high blood eosinophil count, they've never been a smoker, treat those asthmatic features with an inhaled corticosteroid. Quick through about comorbidities. Dutch study went to review patients and found only about 5% of people with COPD had just COPD. Most of them had other long-term conditions. And these long-term conditions aren't unsurprising. Coronary heart disease is the commonest cause of death in people with COPD. So we should really be thinking, anyone with COPD, have we tried to evaluate their cardiac risk? Heart failure is very common and the average age at diagnosis of heart failure is about 74, whereas the average age of diagnosis of COPD is 65. People with COPD for a number of years often develop heart failure. Erectile dysfunction, not always the easiest topic to discuss with patients, but again, a very early sign of coronary heart disease and very common in COPD. And if you think about osteoporosis, thinning bones, that's very likely to be common in someone who's not exercising a lot. Certainly if they smoke a lot, again, another risk factor. And if we've been using a lot of oral corticosteroids with that sort of patient. So again, a lot of these comorbidities we can predict will give problems. One of the interesting more recent developments has been a recognition that men and women often have problems with incontinence, cough. When they're coughing a lot, they tend to leak a little bit. Certainly in our country, quite a lot of women will present with this, but very few men come forward to say, I'm leaking a little bit in my urine at times. And that in itself is something that when we actually look at groups, find it can be the same. Actually, the men are just as affected as the women in people with COPD. But don't forget comorbidities. Very quickly, this is similar to the last one. Check the diagnosis is right. Check their symptoms are caused by COPD and not something else. Do a proper review, listen to our patient, and then share decisions as we go through. If I move on quickly to effective treatments, this was something we did back 10 years ago now. The most cost-effective intervention for COPD is flu in the UK. The second most is helping them to stop smoking. The third is getting them exercising more and educating them about their disease. Then we get into the drugs. So if money is a problem in a healthcare economy, we are better concentrating on the lower end of that market, but still use the upper end. And certainly from the point of view of our evaluators, they say the drugs are still efficient enough for us to be using them. Rupert Jones, GP down in Plymouth, along with colleagues from Australia, Holland, looked at something called the dose index. And if you want one quick takeaway from what should I think of when I see somebody with COPD, number one, breathlessness. And we call that the dyspnea score, breathlessness score. And that's the D in dose. If you're very breathless, you have a worse prognosis than if you're not very breathless if you've got COPD. The second one, the level of obstruction, is the FEV1. You might be doing the peak flow with that. The lower the peak flow, the lower the FEV1, the worse the outcome. S is for smoking. If they're smoking, they're more likely to have a worse outcome than if they quit. And finally, exacerbations. The more exacerbations somebody has, the more likely they are to have problems. So if you want a very quick review system, think of dose and then check that they can use any inhalers properly and think about other interventions and comorbidities. Last bit, exacerbations. I'm going to keep this very brief. Exacerbations are thought to be the thing that cause that step down decline in lung function. It's not a smooth line that people used to think of from the Fletcher-Peto graph that many people are familiar with. If you're going to start a short-acting beta agonist at the onset, that's good. And if you want to use steroids and or antibiotics, most people would start them between 1 and 3 days after the start of their symptoms. Most exacerbations will last around the 2-week mark, with 50% lasting longer than that. And that's important because in terms of the treatments, if somebody comes back to me and says, I'm not better yet, can I have a longer course of antibiotics and steroids? I probably should be saying, no, I need to check that you haven't got proper pneumonia, different treatment, pulmonary emboli, quite common in those with persisting symptoms, heart failure, atrial fibrillation, or another cause. And if it's any use, the recommended treatments at the moment are all bodies around the world now seem to agree with 5 days prednisolone at 30 milligrams and 5 days of an antibiotic. In the UK at the moment, that's doxycycline. It may differ microbiologically in different parts of the world, but it's a 5-day course, and that should be sufficient even if the symptoms are slowly improving 2 to 3 weeks in. So just to thank you again for all the work you've done in your country. It really is appreciated. I think we're part of one big body around the world, and we should be all trying to stick together and working together. And if you get a chance, look at the IPCRG website. Thank you very much.
Thank you. Thank you, Dr. Holmes. Thank you very much for your concise and review of both asthma and COPD. We're getting a lot of thanks from the participants from Yemen and elsewhere. We've got a few questions for you. Would it be okay to take the questions?
Yeah, sure.
Brilliant. First question. Should each patient be recommended to have, I suppose this is for asthma, should each patient be recommended to have their own peak flow meter, or is it enough that they do their peak flows in surgery when they see us?
I would normally want them to do the peak flows when I see them in the surgery if they haven't got an acute infective process going on at the time, when they might be coughing out aerosols into the environment. But yes, I would want to see them do it in surgery because of that variable effort. There are a few people who might benefit from having that at home, but most people can say when their symptoms start to worsen at an early stage and recognize that themselves. so they don't have to have the peak flow meter themselves.
Great, thank you. There's a question with regards to pollution, and whether it's a contributing factor towards obstructive airways disease, specifically in children. So your advice with regards to that, and if anything can be made to manage and ameliorate this.
I think worldwide we're recognizing increasingly the problems with pollution, and certainly some of the triggers that precipitate acute respiratory events. And thank goodness the world is now trying to address that in some way and slowly making progress. So there certainly is a lot of interest in pollution. What I think is unusual at the moment is, and if we think about this with smoking, quite a lot of our patients who smoke don't get COPD. Indeed, probably only 20% of those that smoke will have evidence of COPD on their spirometry. The same is true for air pollution as well. Lots of people certainly in London, we have the lowest prevalence of asthma, but the worst pollution in the UK. And around in other parts of the country, there are much higher prevalences, but virtually very little pollution. And so we're either questioning, is practice in London not very good and they're not picking up these people? Or how much impact does actually air pollution actually have on our patients with this? It is still quite a controversial area. I think pragmatically, from where I am as a general practitioner, some of my patients will try and remain in if pollution is bad, and will try and avoid certainly exercising near busy roads where things are very toxic. But in the same sense, a lot of those will have no choice in their environment. And I do remember coming back from a very polluted city and arrived into an airport where there's lots of pollution, and sat in a bus station and thought the air felt very fresh and clean again. And I suddenly thought, crikey, that if I'd have been normally coming to that environment, I'd have thought it was very poor air. Pollution is everywhere. We have to live with it in our clinical world, I'm afraid.
Thank you. I think we're all a bit taken aback in terms of the shisha pipe being equivalent to 100 cigarettes. I think there's a question in regards to, and perhaps this is a question, hint for us to share for the Yemeni participants, which that we can maybe we can discuss this on the forum that we've got on WhatsApp but it's a question in terms of the process of like preventing smoking and stopping smoking as a public health measure. Well, I suppose education of patients is key for this, but could you give an indication to how to proceed as physicians?
Okay. Yes, very, very quickly. Sometimes you can get into a very long argument with a patient saying you should stop, and they say, I can't because. And so in the UK and in quite a few other countries around the world now, and again, information on the International Primary Care Respiratory Group website is about very brief advice. If someone says they smoke, the advice I want to give them is, do you know the best way to stop is with professional support and some of the medications we've got available? Would you like to have that now? That's it. I don't want to rant at them about how bad it is for them, because they virtually all know it. They might need a reminder once in a while, but most people know. What I want to do is say, and we know certainly in the UK, most people do want to stop smoking. It's not, if you said, oh, we can help you to stop, and that's it, you'll be stopped by tomorrow. They'd say, yeah, that's great, because I can save money. I won't be hooked on these horrible things. My clothes won't smell, etc., etc. If we can do that, we can make a difference. So a lot of it is around brief interventions and having some support to help. And we've trained up healthcare assistants within our practice, so like an educator or a receptionist, to provide that sort of advice to patients, and also to help them with the smoking cessation area, because it would take up too much doctor time, if you like.
Okay, thank you. can I just thank you again, Dr. Holmes, for the hour that you've given us and for your time and support of the Yemeni medical community and their population as well. And I just want to also extend thanks to the INTERYem backroom team, the trustees, of course, but also the management team, Dr. Wahib, Dr. Mubashir, and everyone else who've been making this such a fantastic program. And as you know, we're on our second day. It's been an honor to be able to chair and help this morning. And just to let you know that in half there's a break now. The next lecture and will start in half an hour's time with Dr. Helen Crawley. And so look forward to seeing you then. Let me just say that in Arabic. Inshallah ستكون فترة للراحة إن شاء الله لنصف ساعة إن شاء الله. وبعد ذلك لنبدأ بمحاضرة من دكتور هيلين كرولي. and inshallah نشترك بذلك. Thank you very much again. Look forward to seeing you in half an hour. Take care. Thank you.
Hello and welcome back, everyone. I, internal paediatric nurse, am honoured and delighted to introduce our next host, Dr. Helen Crowley, who will be discussing the international nature of family medicine, learning from colleagues in other countries. Dr. Helen Crowley is the International Medical Director for Membership and Networks for the Royal College of General Practitioners of the UK. Dr. Crowley is a practicing GP who has been involved in training and teaching for 30 years. Her experience involves teaching Oxford University medical students and supporting primary care tutors. She has also developed and delivered multi-professional and interprofessional training for primary and secondary care health professionals in a wide variety of areas, mainly focusing on general practice. Her particular interests include quality improvements in primary care, consultation skills, and the development of non-medical prescribing. Within the RCGP, Dr. Crowley set up primary care development, supporting practices to improve the quality of services they deliver in the UK. In her international role, her focus has been on developing training and assessment in family medicine, and on improving the quality of services delivery provided by doctors and other healthcare workers in primary care. She has led a number of projects, mostly in Asia. I'd like to hand over to Dr. Crowley, and thank you, Dr. Helen Crowley, for giving up your Sunday afternoon in aid of Yemen and the healthcare system. So take it away.
Thank you very much indeed for that lovely introduction. Thank you very much indeed for inviting me to speak at your inaugural INTERYem conference on the really important specialism of family medicine. I think that's a really important thing that you've done, and I'm delighted to be part of today.
You're most welcome.
So you've already introduced who I am. I am a general practitioner, and I have a number of non-clinical interests, as well as being a generalist in my clinical care. And you've already described how I've got a wide experience, but I'm not a specialist in anything. However, I have found that working part-time initially to look after my family, and then expanding my roles as my time became more available, I've dabbled in so many things, and they've been really useful as I've brought them together in a variety of projects, including internationally. What I'm going to do over the next 30 to 40 minutes, leaving I hope plenty of time for questions, is to look at the sort of familiar stories that I've heard in my work as International Medical Director and my work as a volunteer internationally. I'm not saying that these are stages that one follow the other, but they do seem to be the sort of themes that come out of discussions with family medicine development organisations and projects around the world. And indeed, we've heard many of those themes echoed yesterday in the descriptions of the development of family medicine, both in the Yemen and in Africa. At the start, there's often a core group of family medicine practitioners who are really passionate about what's going to happen and how to develop their profession, and they're usually supported by some specialists, some hospital specialists. There are national concerns over the quality of service delivered and over whether practitioners have appropriate skills. Indeed, what are these family medicine doctors supposed to be doing? Slowly, there's an integration of family medicine into national health systems to reduce referrals into secondary care. And in the UK, basically GPs are sort of running the health service now. I note that your focus is on training, education and research, and I've written some key words in red, which I'm going to dot throughout my presentation, which I hope will be very practical for you, and see if I've missed any red lettering along the way. Those are peer support, and of course what you're doing today is bringing together a bunch of enthusiasts, and you're looking for peer support both internationally and within your own country, and also amongst your colleagues in your locality. You are the passionate voluntary early adopters, both nationally and internationally, supporting the development of family medicine in Yemen and looking to other worldwide systems for ideas and to bypass the themes that have not been helpful to other countries as they develop to learn from everybody's learning so far. And underpinning all this I cannot emphasize enough that it is useful to gather data, whether that's qualitative, quantitative, the odd survey, to just back up what it is that you've done and what it is that you've achieved. Because writing this, I looked back and thought about what had been achieved in some of the projects that I've been involved in and whether we'd collected enough data to demonstrate their true benefit. The first thing was this core group of family medicine practitioners, and for that I'm going to talk about the history of the Royal College of General Practitioners. Yesterday somebody spoke about how it was taking 22 years to develop family medicine training. Obviously, I hope that you managed to work more effectively and quicker than we did, but the journey is always going to be long and it's always going to be continuous. In 1984, the NHS was created in the UK, which provided universal health coverage in that care was free at the point of delivery for the entire population. And within 1 month, 90% of the population had registered with a general practitioner who was seen as core to the delivery of universal health care. However, things weren't quite as rosy as you might expect. So an Australian gentleman called Dr. Collins came across to look at this exemplary National Health Service, and he went into GP surgeries. He was shocked and appalled to find that there was really no quality assurance. Most GPs were single-handed, and there wasn't a general system of quality improvement, quality assurance, or even professional qualifications. A couple of doctors reading the report in the Lancet, 2 GPs, talked to each other and decided to create a Royal College, a College of General Practitioners, which later became chartered with a royal in front of that title. And they had this big idea that they were going to start in a very small way with a core group and then expand. So let's see how that went. Well, it's been a long, slow journey. Initially, that core group of voluntary enthusiasts met together. They were more GPs than hospital specialists, but hospital specialists were important in the recognition that these were family medicine doctors who were going to do a good job and set something up. It was based around the concept of local faculties, which were local peer groups. So in new locality, you would find like-minded people who were trying to improve family medicine. And slowly, the profession of family medicine, or general practice as we call it in the UK, became more regulated and more professional with that. So eventually training became compulsory. Then you had to undertake some sort of examination. And in the last few years, we've also had regular surgery inspections to the premises, as well as the quality of the individuals delivering the service as doctors. I would imagine that somewhere along your journey, you are going to have some sort of group of professionals, and that will be a college of some sort. So it's well worth considering questions. And as I go through, I'm going to be really posing questions it's worth considering rather than saying what should or shouldn't be done. Is your college going to be inclusive or exclusive? How are you going to define what a family medicine doctor is? Is that somebody who's achieved a specific qualification, or is it the job that they're doing? Is it the job they do most of the time, or is it the job they do in the evening? For example, in many countries, public sector specialists work in evening general practice roles. So they're delivering both specialist care and what they would describe as family medicine in the evening. Are you going to allow allied health professionals to join as part of the primary healthcare team, for example, patients to join as stakeholders in this? If so, what level of qualification are you going to say is necessary for membership? And are you going to have a variety of types of membership? For example, we have associate and affiliate memberships, including international affiliate membership, which is actually remarkably good value in the Yemen because it's a low-income country. What context are you going to be drawing from? Is it going to be from your just the public sector, the private sector, combination of both? Is it going to be people who have literally first contact care, or are you going to have more of these consultants in family medicine that were described in South Africa yesterday, who work at the district hospital level? What is your model of care? In the UK, we're very keen on the treatment of individual patients, and usually individual patients come to see us as individuals. Although we may know the rest of the family, we don't consult with the whole family, and we never divulge from one patient to another what other family members have said without their express consent. In other cultures, the whole family is treated, and discussions with the whole family coming to support the patient within that group are very common. So I've seen entire couches, so an entire family can come in. And in other cultures, the place of the patient within the community and treating the whole community and looking after the health of the whole community is very important, especially in Africa and much of India as well. To what extent is your college going to be part of professional development? Are you going to be the guardian or the regulator, or are you going to be the advisor and explain what a curriculum, what standards could look like? To what extent are you going to be involved in education and training from undergraduate to postgraduate and continuing professional development and beyond? Are you going to have allied health professionals as part of your education and training programme? And to what extent are you going to be involved in the regulation or the provision of education for those doctors who are already working as family medicine practitioners? A really strong role is that of advocacy to patients, to society, to governments, to regulatory bodies, to other professions, both allied health professionals and specialists within your country and internationally. It's really important that family medicine is recognised as a rewarding speciality in its own right. And even in the UK, my daughter, who's now training to be a GP, was asked as a medical student, what do you want to do general practice? Why waste your talents? You're a really good doctor, potentially. The role of family medicine as a gatekeeper is absolutely crucial to the delivery of universal health care. And that is a very strong argument when you're talking to, for example, ministries of health about how health economics is going to work within your own country in context. Integration of health and social care really does rely on family medicine at its core, and we all need to learn from models of care elsewhere in the world. The NHS is often seen as a model throughout the world because we've been going so long as the universal healthcare system, and we have family medicine at its centre. But of course, funding, resource and workforce issues remain even here. Paying conditions may be something that a different body in the UK, we have a union type body called the British Medical Association, which negotiates on that. But we do also provide data. So a recent example of how data was useful, and I think data in every aspect of this journey is absolutely crucial. It was seen that there were considerably fewer patients attending GP surgeries during the pandemic. And indeed, in the first 3 months, the number of consultations went down. But the number of consultations in primary care has been very carefully tracked. So even in the last quarter of last year, when GP surgeries were still relatively free of physical patients in the building, it was found that the number of consultations had gone up by about 30%, and the workload was actually truly great. And some of the workload that wasn't recognised, for example, identifying patients at risk, could be included through careful data collecting. And this is a classic slide showing that how in the UK, general practice receives about 10% of the funding, but does about 90% of the work. As you set up your college, there are a few pitfalls I've noticed. It is worth having one voice. There may be separate voices for paying conditions versus the standards and the ethos of family medicine. But if you have a lot of family medicine colleges trying to give the same message, that message becomes mixed, and it's not so good if you're trying to go to government and society to explain your role and importance. It's important to consider those who are really experienced family medicine practitioners within your country. Are they going to have grandfather's rights and entry into the college through some sort of description of their portfolio of career experience so far? And the negotiation of standards can be quite political. So your college may be aspiring to high standards. The practitioners who are actually delivering the work may be unhappy that those high standards are being negotiated as a gateway into the profession with the government, with patients and with society. So actually setting standards can sound like it's an easy thing to do and a good thing to do, but there may be some comeback from your own body as well as from society at large. And this is what we look like now. Quite a growth in 70 years. The second thing I'm going to talk about is the quality of care. Generally speaking, as family medicine is developed as a new speciality, there's a misunderstanding of what it is. There may be a suspicion of family medicine as a speciality, and particularly if it's primarily delivered through private care. So it's really important to honestly recognise what the situation is and address any issues.
Sorry to interrupt, Dr. Crowley. Yeah. Would you like to share your slides?
Oh, can you not see them?
No, sorry.
Oh no!
I didn't think you. Yes.
Oh my goodness! Right. Okay. I was on. Where's my Zoom gone? That's really annoying. Sorry about this.
No, not at all.
I can't even find my Zoom anymore. So I have to borrow a friend's computer. Zoom. Share screen. Ah, right. Sorry, I had pressed that. I'll just sim through to what I've done so far. Sorry about this.
No, not at all, not to worry.
So looked at the cost, and this is the college. So I've talked about this understanding of what quality of care is, and there are two models that I've used mostly in my work on this nationally and internationally. So internationally, we've used the INTERYem model, both for quality improvement, so you need to know where you are in order to improve, and quality assurance, what are the standards that are being set that you need to reach in order to be recognised as an accredited practitioner environment, accredited practice. So the INTERYem model looks at structure, process and outcome, and it was written in 1988, but it's still used in quality improvement work in the NHS.
Sorry, Dr. Helen, have you managed to share your screen?
I have, I thought.
So have you gone to the bottom of your screen?
It says share screen.
Yes, and has it allowed you to share?
Who can share? Only host.
Okay, so the host shall allow you to share your screen. So you're the host, so you should be, so you're the host, Helen, at the moment, so you should be able to pop it up. If you've opened it up on your, if you click your PowerPoint off and then click it back on.
Can you see my screen at all now?
No, not yet.
So I've got share. Open system preferences. Whoops, it's not showing then.
What does it say when you share your screen?
It says, oh, I've got share screen, desktop, share, and it says open system preferences.
If you can't put it on, you can always send it over to INTERYem, Mubashar, and he would be able to put it on for you. Do you want to email it across?
Right. Sorry, I'm not using my computer. This is so irritating, actually. I practiced this last night.
I understand. Not to worry. Take as much time as you want.
Right. Sorry.
It's fine.
It's not. This is terrible.
It's a Sunday afternoon, so I'm sure all the attendees can understand.
Right, fine. So can you tell me the email, because I'm not on my own computer? Mubashar.
Okay, he should be able to send it onto the chat.
Is that
I should be able to bring it up
Sorry,
for
I've
you.
had to send it to my own email, send it back out again.
No, that's absolutely fine. So it's Dr. M. Chowdhury, which is CHOUDHARY at outlook.com.
INTERYem dot.
Yeah, you can put that one.
It hasn't come through. At INTERYem.com, yeah?
Yes, .co.uk. .co.uk. So it's mubashir.chowdhury at INTERYem.co.uk.
Right, okay, hopefully that's gone. I'll carry on explaining things, then we can look at the slides. I'm really sorry about this.
No, it's absolutely fine. We was engaged without your slides, but I thought it might help the audience a bit more.
Right, have you got them now? Have they arrived?
So if you want to just carry on, and then if he's able to, he'll put it up. If not, we're engaging very well without slides at the moment. So
okay,
yeah,
fine.
Yeah, just carry on.
Right, PowerPoint. So I was talking about the Dombidium model, which was arranged in 1988, and it looks at structure, process, and outcomes. And then in the UK, we have a Care Quality Commission model. And I'm just going to talk through the Care Quality Commission model, which looks at safe care. So, for example, are your vaccines correctly stored? Are you learning from mistakes? Is your building safe? Whether your care is effective. And for that, you need to be auditing against standards, and you need medical records for that. Now, medical records is a big issue in virtually every project I've been involved in. It's quite normal for there to be no or little medical records, and certainly something that isn't auditable. And when you're trying to design your medical records, there's a huge international understanding of what that can mean. One of the common errors I've noticed is that quite a lot of different systems are set up simultaneously, and that the medical records are devised more for public health reasons than for the use of general practitioners who are looking at a longitudinal record from cradle to grave and may wish to, for example, find all the patients who have diabetes in order to set up a diabetes clinic. You need to be caring for both your patients and your staff, and responsive to the needs of your patients, including for opening hours, services and access. And of course, in order to achieve that, you need good leadership, and that should be looking continuously to improve, to educate and develop. And for all of that, you'll need data, and the sort of things we're able to measure are outcomes, because we have computer systems, patient satisfaction surveys, significant events, training, fridge temperatures. Every sort of bit of data is collected continuously. And we use that, first of all, to decide what our improvements are needed before the inspectors come, and then to provide to the inspectors. So when you're devising what quality standards are going to be, you need to know what the quality standards should be. Are they good enough? It's great to aspire to excellence, but you need to be good enough in every area of your practice. And you may wish to grade your standards from inadequate, requires improvement, good or excellent is what we use in the UK. those standards have to be acceptable to public society and the profession and the state as a whole, which we've already talked about how that negotiation can be complicated and political. Standards are likely to rise over time as things improve, and you need to decide who those results are going to be published to. If you're trying to do an improvement project, it's often better to keep those results confidential so that people can be open and honest. And as you actually start to accredit practices, you may wish to publish what the standards actually are and what was achieved. We've run a very successful quality improvement project in Myanmar with the Myanmar GP Society under the umbrella of the Ministry of Health and Sports quality standards and plans. So in 2017, it was noted that there were concerns over the quality of general practice from seniors who were all specialists, no senior GPs within the advisory boards to the Ministry of Health and Sports. So we collected some quality indicators, and it was very important that these were indicators, not standards. So we were looking to try and scope what the level of delivery in family medicine was, and it went from having very limited facilities up to ultrasound machines within surgeries or even x-ray machines. 2018, we undertook a number of visits from the UK, and we visited practices, did a peer support visit, using quality improvement tools to run groups with them, to identify learning needs, do significant event analysis, to audit outcomes, develop learning logs, and we ran peer support quality circles, which we facilitated initially, and then the participants on the study ran them together, and they addressed their learning needs and resource needs between the meetings that we ran. And throughout that, we measured the quality indicators anonymously at the beginning and the end of the project. We encouraged a patient satisfaction survey and audited some outcomes of care, even in the absence of effective medical notes. In 2020, we pivoted to a remote project involving COVID, but fortunately we had some graduates from the first scheme who were able to act as in-country co-trainers, and the remote nature of access meant that we could improve the liaison with secondary care, public sector clinics, NGOs throughout the whole country. Although having localities in which we'd built up a really strong core of quality understanding was really important, and then we moved to new areas in the second phase. We found that the practitioners were happy, felt less professionally isolated, that we fed into CPD and reaccreditation discussions so that reaccreditation did not rely on sitting in a darkened lecture theatre. We fed into masters development so that the masters project would not necessarily be a research project, but could be a quality improvement project. And it was planned that WONCA would hold its Asia Pacific conference in Myanmar this April. But unfortunately, in the meantime, there's been a military coup, and the practitioners who were part of the project were able to group together. They knew each other. They've been delivering care in very difficult situations, and they've learned a lot of new skills from each other through their support networks, for example, on the management of gunshot wounds. We feel that we developed leaders of the future. One of my colleagues in Myanmar said, you came in 2015 and you told us about consultation skills. Now you're telling us about quality improvement. I thought this would cost a lot of money, but you told us about learning logs, personal development plans, and we are now meeting quality circles, and we learn from each other. And that was a really valuable lesson. And they've grown and grown since we left, actually. The next stage is appropriate professional skills, developing family medicine as a speciality. You may need to consider what undergraduate training you're going to be involved in. Placements often start in community medicine, then move into family practice. Initially, teaching of family medicine is by non-family medicine doctors, but then you start to have a department of family medicine, which may initially be in community medicine departments and then moves out to its own department, its own professor. You may have doctors who are family medicine practitioners teaching a small part of the curriculum, for example, consultation skills, and then moving out to teach more widely within the medical school. And in the UK, some medical schools are now predominantly taught in primary care by primary care physicians. Then when you come to postgraduate training, you have to decide when in the career is that going to happen. Do you need practitioners who had some element of postgraduate experience first, or are you going to go straight from MBBS? What level of training are you aiming at? Are you going to provide the clinical skills needed to function as a first contact doctor, or are you going to focus as well or later on professional behaviours, including leadership, quality improvement and research? Is your training going to be an apprenticeship, an academic program? Is it going to be predominantly hospital-based or community-based? Is it going to be online, face-to-face, blended? How's it going to work? Why do you need a qualification? Is it for the competence and competence of your practitioners? Is it as an entry qualification to family medicine, as it is in the UK? Is it to allow you to be a respected teacher to other practitioners? Is it to advance your career? And how are you going to deal with those who do not have the opportunity to undertake extended periods of trainer, grandfather's rights? How are you going to maintain the standards once people are licensed, and to what extent is your college going to feed into that process? Are you going to be regulating, or are you going to be advising? So I had a lovely quote which exemplified how family medicine can be recognised through these quality initiatives. Nephrologist to patient in India: I would like you to take these new tablets. Patient: I'm going to check with my family medicine doctor first. Nephrologist sighs, but inwardly he does recognise that it is the family medicine doctor who knows the whole picture. The next thing that's important is integration of family medicine into the national health system. This could be across levels, for example, from community health workers, allied health professionals, hospitals, including first contact and specialist care, and across providers in the public, private, charity and NGO sectors. Often there are various vertical programs, for example, HIV, looking at specific illnesses, or specific age or conditions such as maternal and child health, and those need to be integrated into your overall system. This can only be done through collaborative discussions, through trust, through written strategic plans, but also through detailed thinking about how you're really going to implement it in practice. How are you going to pay if private care is involved? Often this is through essential packages of health service, through social franchises. That's quite a common model, through something called PSI, and specific problems may be financed. For example, private practice may start to be involved in TB programs or vaccination programs, rather than that just being done through the public or NGO sector. You're going to need some protocols. I often things start with informal agreements. So, for example, if a patient has got a condition which could be treated for free, they may be recommended to go to the local public hospital. But that can be formalised, and obviously the more formal it is, the easier it is to make sure that people don't fall between those gaps. The minimum to me seems to be shared records, and those as a minimum should be a letter to and from providers, but obviously shared medical records is something to aspire to, as I've discussed earlier. And little things like practicalities: are there going to be beds? Is there going to be a doctor there waiting to see you? Is transport available? How much is it going to cost the patient, both in terms of the service provided, the tests, the medicines, and even the transport costs? They can be a barrier in the UK as well if ambulance services are not available for that condition. So now in the UK, we are running the health service. We're expert medical generalists. We have an enhanced specialist role. We lead and coordinate the whole of the primary healthcare team, which is now massive with many, many different professions in it, which is a whole lecture in itself. We're educationalists for allied health professionals from undergraduate to postgraduate level and beyond into continuing professional development. We're researchers, and many surgeries in the UK are part of research networks, even if they're not doing research which they're initiating themselves. We have a public health role. In the UK, that's really underplayed, but I think in COVID we've recognised that care of the community is an area perhaps of family medicine and primary care that we've neglected in the UK. And my daughter, who I've mentioned previously, is actually about to do 3 months of public health training in addition to her GP training if she gets onto the scheme. We provide governance within our practices and of other GP practices, and more widely within the healthcare system. We are role models, I think. And we also now commission secondary care and other services in primary care. For example, we have district nurse and health visitor and midwife visiting services, community mental health services, etc. And it is GPs who are fundamental to the commissioning of those, and we are core to the integration of those services, with the patient at the centre, primary care acting with the patient, the community services and first contact services around that, and then on an outer circle, the secondary care services. So I think I've given you a view of how it is that a core group of enthusiastic doctors, predominantly family medicine specialists, can support quality improvement informed by data collection and training to agreed standards to facilitate the integration of healthcare systems with primary care at the centre, led by family medicine practitioners. Thank you. Hello.
Hello.
Right.
Hi, so we've got a few questions here for you. You okay?
Yep, lovely, thanks. I'm sorry about that.
It's absolutely fine. So thank you for the nice talk. It was very engaging and insightful. The question is, what kind of cooperation with international organisers should family doctors in Yemen do? I mean, like, then the question is, should we focus on the training or on the exams or developing services or something else?
Oh, right. So where should you start, in a sense? Right.
Yes.
Okay. So I think Wonka's been mentioned a few times, and I would definitely send delegates to the World Association of Family Medicine Doctors. It's really inspirational to go to the lectures there, to network and to meet like-minded people. So they're geographically organised, and also there are world conferences as well. So you can learn a lot and cooperate with people who are in similar situations, whether they're throughout the world or whether they're in your locality. And I think that's really important. If you're trying to be accepted as a service, then I think it is really, really useful to show that you're providing a quality service. So having some model of what quality means in your context is really important. And you can collect basic data like how many patients you're seeing, the sort of patients you're seeing, and just some sort of reflection on what you're doing. Trying to demonstrate that you've improved the healthcare of a population takes years, and it's a very slow process. But you can demonstrate what you've done, who you've seen, what difference it has made to those patients, where else they would have had to go, how you've prevented referrals into secondary care, etc. So both demonstrating descriptions of the care that you've given and numerical facts around how much care you've provided and what the effect of that has been. If you can have discussions amongst your profession about what quality means, then that's really important. And that's important across the whole of family medicine, because you're going to have a lot of people who are practicing family medicine either by qualification or by the job role that they're undertaking. But you are almost certainly going to have a small core of people who've been trained to a high level in the concepts of family medicine, its importance, how it's delivered, its leadership skills, training of trainers, quality improvement, etc. And those individuals are going to be working as a group to move the profession forwards as a whole. Is that helpful?
Yes, it is. And in terms of policy change, and how do you go about actually influencing policy change?
That's a question I've been asked quite often, and it's down to evidence. You have to have the evidence of what you're doing. You have to explain how you're different through perhaps publishing case studies, looking at a patient where, as a family medicine practitioner, at the core of that family, at the core of that patient, seeing all their conditions together has been important for the patient's care. You can demonstrate how you've actually been cost effective, how you've managed patients to the correct standards to prevent for example, the consequences of uncontrolled blood pressure, how you prevented those referrals into secondary care and protected the health system as a whole.
Okay. What's your advice about encouraging young doctors, medical students, to become family medical doctors? Do you have any wise words?
Yes, the first thing is that if you don't see family medicine, you don't know it exists. So when I was a student at Oxford, they had a couple of spare weeks that they needed to fill with something. So they sent us all out into general practice for 2 weeks, by accident rather than design. And it was really important in orientating us towards how our community worked and where patients came from into secondary care. Usually the family medicine component of training in the UK is the most highly rated, because you have individual time with a passionate practitioner who shows you what can be done. And certainly in my practice, we've had a number of people who came as considering medicine as a career. They came and sat in for a bit, saw what it was about. Then they came back when they had to do some family medicine. And then actually one or two of them, they didn't come back to work for our practice, but they did go into family medicine. And they said that their time with us was really important to understand how rewarding it is, and that it isn't boring, same, no more. It is the whole of medicine. We see everything, and we see it in individuals rather than as in patients, as diseases. We see it as people.
Thank you. The next question is, dear Professor Helen Crowley, thank you for your talk. How can we work with the Royal College of General Practitioners? Does it have to be with the Ministry of Health, or can the university work with the RCGP?
When you're setting up partnerships, you need a funding organisation ideally. And I know that THET, for example, Tropical Health and Education Trust, has worked in partnership with Yemen in the past. In those partnerships, it is usually organisation to organisation. So we're a professional body, and you may have a professional body or a university. So it's sort of delivery training bodies that work together. But we would always do that within the overall plans of the Ministry of Health. And indeed, generally speaking, the Ministry of Health is a partner, but they wouldn't be a lead partner. The lead partners are those who are actually going to deliver the changes that are needed.
Okay, thank you for that. And also next question, which is the good organisation to cooperate internationally?
I would say WONCA is a really good international organisation based on family medicine. Of course, when you're looking for partners for the strategic development of your health services in delivery institutions, I would take advice from neighbouring countries, from countries who are in the same level of development of your healthcare systems, who may be facing the same problems, such as a conflict area. So take advice from, for example, I think we're hopefully going to have a project in Somaliland, and we're still very much in contact with Myanmar. So those are areas which have not faced or are facing similar problems at the moment. And then also looking to models of care which are like the ones that you possibly are working towards. So that often is based on historically where your doctors have trained. So they may be looking back to their alma mater, or they may be looking at areas. So for example, in Africa, community care is a very common concept. So, you know, African countries tend to look at each other for models of care. But then, as we heard yesterday, you may be looking to centres of excellence for advice on assessment and on training of trainers, even if the curriculum and delivery systems are going to be different. So, you know, things like the RCGP are extremely good at those specialist areas in supporting development in the way that you wish to develop. And that's the main thing. You have to have your own model, and you don't want to throw out the good with the good when you're developing your model.
And do you think the Arab board is better for training our Yemeni family doctors, or the actual MRCGP?
I think that's entirely personal decision, because it's what actually you want that qualification to mean and do for you. Certainly the MRCGP, the graduates that I've met of it, they found that their personal journey towards the knowledge that they've gained and the consultation skills that they've gained has been really important for their personal and professional development. But I'm not the Middle East expert, so I couldn't possibly comment on that.
Okay, that's fair enough. And what are the most, got a question here, what are the most important qualities to make me a good family doctor? And thank you for your advice in advance, Dr. Helen.
Oh, lovely. I think I love the job. I'm really honoured to be able to hear patients' stories. Sometimes you're the only person that ever hears that story, and that's really, really a privilege. And I think actually there are three things that get you through the day. One of the consultation models. One is empathy, that you empathise with your patients, that you walk with them. You're not of them, but you walk with them and walk their journey and understand what their needs are, and understand what they're looking for, and really care. That's really important. The second thing is that you have curiosity about them as a person, curiosity about medicine, curious about their conditions, curious about what happens to them, what's going to happen next. You can't wait to see them and hear what the next instalment is, what's going on. And the third thing is professionalism. And even on a bad day, when your mind and body are possibly exhausted, for example, in the pandemic times, and when you have the stresses in your own life, then your professional standards are really important as well, that you act with integrity and professionalism, and that you treat all patients equally, non-judgmentally, and as part of a joint shared journey.
Okay, lovely. Also, so I can see that, Dr. Helen, you've been to a number of countries. So what's your opinion about how family medicine is practiced in other poor countries?
It's so many different models about what family medicine actually is. And in all countries, there are individuals and institutions delivering absolutely amazing care in exceptionally difficult circumstances. And in all countries, including my own, there are individuals and institutions where the level of care is not so good, despite the possibilities of it being better. And whatever situation you're in, then you ideally would be aspiring to do the best that you possibly can, realistically, being kind to yourself, but also kind to yourself as well as kind to your patients. You've got to be realistic. You can't burn yourself out, but you need to be delivering good care. And I found that across every aspect of the world, really.
Okay. And the last question that I can see on here, why are there lots of ladies who like to be family doctors?
Fine. There are lots of reasons for that, I think. In my own country, the majority of doctors are now female. That, frankly, we're actually better as getting into medical school, that we have those interpersonal skills, the diligence and academic standards needed to get us into medical school in the first place, particularly since it's often entry immediately from school. And probably at that age, a lot of girls are more mature in their academic approach and their psychosocial understanding than perhaps some of the males around them are. So I think we're getting in. Then the care of people rather than the practical doing often appeals more to women, I think. And there are some very good lifestyle advantages in terms of the training and delivery of care. So in the UK, for example, you can work sessional jobs, so you can just do occasional jobs fitting around the rest of your life, and that's been quite important to quite a lot of us as we come through. And then we filled the rest of our week with other things, for example, leadership roles, which has been an exciting part of the second half of my career.
I think that quite answers it. And I think that women tend to have, not saying that men don't, but they tend to have that 6 C's of care, compassion, considerate kind of nature. And I think they kind of work well with their patients, don't they, in terms of being a practitioner, I think.
Yes, I think one of the things that I think the Royal College of General Practitioners has developed is a consultation skill model. And our model which is not appropriate worldwide, but is what we do in the UK. So we see the patient as an expert in themselves and the doctor as an expert in diseases. And what we're trying to do is meet a shared understanding as equals in the room together. And that equality of approach may not be something that somebody who's more of a doer and a curer does, rather than somebody who literally sits alongside their patients, sits alongside their trainees, sits alongside the health systems they're trying to support, rather than trying to dictate what should be done.
Okay, and I think we've got a couple of more questions, if you don't mind, that is.
No, it's lovely.
No, how did the family doctors become the leaders of doctors in the UK?
It's amazing, isn't it? So I think a lot of different pressures. One was that a few years ago, there was something called fund holding introduced, which was that groups of doctors were going to purchase services from secondary care. I suspect that part of the political imperative for that was that the secondary care services weren't always functioning. So then it was seen possibly if the GPs were seen as commissioning it, they were given a budget and told to buy care, and then that care wasn't available. It could be seen as the GP's fault, not the government's fault. So I think that's one of the reasons. And of course, GPs are the largest number of doctors in the UK. We're over 50% of doctors. So, you know, we're really important as a body of practitioners. And then basically that's evolved. So we started to commission care, and it was found to be quite effective. Whether it's the best model or not, I'm not going to go into. There are lots and lots of different models. And if you want to look at models of delivery in the UK, look at King's Fund website. It's got very good explanations of what advantages and disadvantages there are. But in terms of medical education, you know, with such a large body, and increasingly GPs and general practice surgeries and general practice patients and primary care were used as part of teaching. And it was found to provide students who were engaged and interested in medicine, and that's grown and grown, really.
Okay, lovely. And I think this is the last question we're going to take. What should we do about family doctors thinking about misinformation about their conditions, like about coronavirus and the vaccines? What's your advice on this topic?
On pardon?
So, about family doctors thinking about misinformation about their conditions, for example, coronavirus and the vaccines. Okay,
so society as a whole seeing things very differently from the way that the medical professionals do. Yeah, is that what you're talking about?
Yes, I think that's what the question is trying to ask.
Right. So I think that's an international problem, isn't it? And as family medicine doctors, we are there face to face with individuals. And generally speaking, your family doctor is one of the people in the world that you trust the most. So my advice is to have individual discussions with those that you feel have got misinformation, if you possibly can. At the community level, you can also do community engagement events, put videos online, explain through your community services what the advantages are, what the disadvantages are, what the context and risks are for the communities that you're working in, of, for example, not being vaccinated, what the context and risks are of not undertaking social distancing, wearing masks, hand hygiene, etc., which you've got your lovely Hands, Face, Space logo up there. So I think we have such a good relationship, generally speaking, with our patients, that what we say is really taken on board.
Okay. Not sure if there's any more questions from anyone, but I'd like to big thank you to yourself and for participating in this conference and giving up your Sunday afternoon. It's been a pleasure. It's been a really insightful talk. Thank you. That's what I've got to say.
Thank you very much for inviting me. I'm very sorry my slides didn't show.
No.
Hopefully they've emailed across to Mobasha at the moment.
Yeah.
And if you'd like any support or help in the future, please keep in contact.
Most definitely. And no, your talk was very insightful without the actual presentation. So you kept us very engaged.
Thank you very much.
Thank you.
Take care.
Thank you. We should be starting shortly with our next host. We're just waiting just for the presentation to be sent across. I think we are ready. So I'd like to introduce our next host, who is Professor Ahmed Fouat, who will be discussing and elaborating on diagnosing cardiology conditions in family medicine. Professor Ahmed Fouat is the Hello, my apologies for that. So I'd like to say that we are going to be introducing our next host, who is Professor Ahmed Fouat, who will be elaborating on and discussing diagnosing cardiology conditions in family medicine. Professor Ahmed Fouat is the Honorary Professor of Primary Care Cardiology in Durham University. He's also a GP appraiser, and a GPSI Cardiology in Darlington, England. Professor Fouat has been involved in a number of societies and has taken up a number of leads, such as past president of the Primary Care of Cardiovascular Society and the CVD clinical advisor to the Royal College of General Practitioners. He's also been involved in Clinical Research Network GP engagement as an engagement lead, an expert advisory group member, and sorry, my apologies, and also part of the Durham, Darlington and Tees Valley Research Alliance. Professor Fouat is also a tutor for the renowned Bradford University Postgraduate Diploma in Cardiology, and also is on the editorial boards of the British Journal of the Cardiology and Primary Care Cardiovascular Journals, and a peer reviewer for most high compact cardiovascular journals and research bodies. His work in the community cardiology has been recognised with fellowships from the Royal College of General Practitioners, the RCP in London, and also the RCP in Edinburgh. I'd like to introduce Professor Ahmed Fouad, if he's ready. And
I seem to be struggling. Thank you for the long introduction, Intihan. You didn't need to give all of that, but thank you.
no.
I sent the presentation to Mobashir. I think I sent it as keynote first. I seem to be struggling to share for some reason.
Yes,
So,
it's okay. We can. You can also start until he gets it across, if that's any good.
yeah, well, I've sent it over now
Okay.
as a PowerPoint. I don't know if you have it. Do you? Is it? I would rather have the slides to.
Oh, well, we've got a few moments, so we could. He's just waiting on to receive it, so we could wait a few moments. It's not a problem.
Okay, yeah, thank you. I will try again to send it.
What email did you send it to, Professor?
To Mobashir Chowdhury.
Okay. At INTERYem.co.uk.
Let me have a look. Yes, INTERYem.uk, yeah. Okay, let me just try again.
You can try this email, which is Dr. M. Chowdhury.
Dr. M. Chowdhury.
Yeah, at outlook.com.
At outlook.com.
Yeah.
So people could perhaps go and make a Turkish coffee or something, or a you have similar. My name comes from Cyprus. I'm a Turkish Cypriot, so I'm brought up as a Muslim. My mother is Scottish, which is an interesting combination. So let me just. So doctor, as in all one word.
Yes.
Yep.
Doctor, then M.
Yep.
And then Chowdhury, Chowdhury.
Yep, I think I've got it.
Brilliant.
Sorry about this. I should have come on earlier.
No, it's no problem at all.
Definitely gone off, and I've sent it to both. So
Okay.
hopefully you have those now.
If everyone can just check, just in case it hasn't gone to junk or anything, for example, or.
It's definitely gone to Mobashir Chowdhury, but the Outlook one seems to have bounced back. So I don't know if I've got it wrong.
No, that's fine. We can.
Any luck?
Not as of yet. You can always send it to mine, which is NOR.
No. What? Sorry.
So it's NOR.
NOOR.
That's 1199.
1199.
At hotmail.co.uk.
Hotmail. Okay.
And I will forward it to Dr. Chowdhury.
It's definitely gone to Dr. Chowdhury, so I don't know if he's not got it. NOOR.
Yep.
1199.
Yep. At hotmail.co.uk.
Heartmail.
.co.uk.
As in the heart.
.co.uk.
Yeah, okay. But heart is as in the heart, HEART.
No, as in at. So if you have a look at the chat section,
spell it out to me.
hang on, it's come through. So we've it's come through at the moment. I think it's come through to Dr. Chowdhury, so hopefully he should be able to put it up.
That'd be great. And will someone be able to forward it or share it back to me?
Yeah, they should be able to.
There we go.
Brilliant.
Perfect.
We got there in the end.
We did, sorry.
Yes, it's okay.
Okay, so do you want to advance them, Noor, or?
You could do that, yeah, from the top section. Have you got control over it, or is it Dr. Bashar?
It says you are viewing INTERYem's screen.
Yes, so he will expand it for you.
Okay. But I don't think I'll be able to, yeah, so someone said they will.
Yes, yeah, so whenever you want the next slide, just say next slide and we will change it for you.
Yeah, that's great. So thank you very much for inviting me. It's been an absolute pleasure to speak to you all over in Yemen. I have been a GP in Darlington, which is in the northeast of England, for 35 years in August. I hope I don't look that old, but there we go. So I've always also had an interest in cardiovascular medicine. And as you kindly pointed out, Noor, I wear lots of different hats, which doesn't always make my wife very happy, as I spend a lot of time with that. So next slide, please. So what I'm very proud of doing is 3-4 years ago, I reformed the Primary Care Cardiovascular Society. We're a community interest company, so not for profit. We do get some funding from pharma, which we've always got to declare, but anyone working in family medicine anywhere in the world can apply to join. So the website is there. We have lots of good resources on site, and we have 2 free cardiovascular meetings per year, which you can also join as a member. And we will be setting up a cardiovascular disease academy in the next couple of months, which will have around 20+ modules, looking at everything from doing a cardiovascular risk assessment to managing heart failure, atrial fibrillation, stroke, etc. So please feel free to join. Next slide, please. So, you know, obviously cardiovascular disease is lots of conditions. I apologize that I don't know what the commonest conditions are in Yemen, but I suspect that they are the same as ours. So these are the 4 main cardiovascular diseases that we encounter in primary care. And I'm just going to spend a little time going through each of them. Unfortunately, we don't have time to go through them in great detail. And I'm assuming that as practicing clinicians, many of you, I suspect, you will understand some of the pathophysiology. So I've tried not to go into that in too much detail. Obviously, I'm also not aware what diagnostics you have available to you and what your referral pathways are, but happy to take questions at the end. So next slide, please. So one of the biggest things we encounter is hypertension, and it often presents to us either directly or indirectly. So I've tried to illustrate some of the conditions with patients I've actually seen myself. So Audrey was a 68-year-old lady who had significant osteoarthritis of her right knee. We referred her for knee surgery. After going through that, she was then brought up for preoperative assessment by a nurse practitioner with an anaesthetist on site if needed. And she has typical comorbidities in the UK of osteoarthritis, COPD, hypothyroidism. She was a smoker, she drinks very little and a bit overweight. And these are the drugs she was on. So they checked her blood pressure in the pre-op assessment clinic and sent her back to general practice saying, these are our blood pressures, could you investigate her before we could arrange surgery? So next slide, please. So first thing to say is that with hypertension, it's a major risk factor for stroke, myocardial infarction, heart failure, chronic kidney disease, atrial fibrillation. It can contribute to vascular dementia and cognitive decline and early death. And even a small rise in blood pressure, systolic blood pressure of 2 millimeters of mercury can increase stroke mortality by 10% and coronary heart disease mortality by 7%. And around 50% of our population in the UK have high blood pressure, and that's increasing. We do have a system of quality outcome frameworks in the UK whereby we are incentivized to detect and manage hypertension. But my initial tests would be, I would do a renal profile, liver profile, full blood count, lipids. I would probably also check their thyroid function. I would do an ECG and I would probably do a chest X-ray too. And then what we're advised to do in the UK is undertake ambulatory blood pressure monitoring or home blood pressure monitoring. And I'll come back to explain that to you in a minute. So next slide, please. Once we've done that, we need to make a diagnosis, and how we triage people for referral for ambulatory blood pressure monitoring, or home blood pressure monitoring is if a patient has a clinic blood pressure of over 140/90 on 2 occasions, we would arrange that. Next slide, please. And the test recommended by the National Institute of Clinical Excellence is ambulatory blood pressure monitoring. And what we do with that is we are looking to get at least 14 good measurements over 7 days. When we give the patient the machine, obviously we need to check things like battery in this day of COVID, make sure the cuff is watched. We get our nurses to fit these, or our healthcare assistants. Patients with mastectomy, bilateral mastectomy, may not be ideal, and those with significant mental illness, or those working in significantly stressful or onerous jobs like heavy goods vehicle, public service vehicle drivers who may be better in farm and having a home blood pressure monitor. Next slide, please. Oops. So what you would get is you would get this sort of reading. We would advise patients to take 2 readings, 1 minute apart, record the second reading, and we would usually discard the first days and then average it out. So you'll see that this patient's blood pressure was 142/75. We would add, now we would say 5/5. We used to say 10/5. And the corrected home blood pressure reading was 152/80. So we would say that this patient has stage 1 hypertension. Next slide, please. So how do we define hypertension? Stage 1 hypertension is a clinic blood pressure of 140/90 and an ambulatory home blood pressure monitoring of over 135/85. Stage 2 is a clinic blood pressure of 160/100 and either ambulatory or home blood pressure average of 150/95. And severe hypertension are those patients with a clinic systolic and diastolic of either 180 or 110. So, you know, these are the definitions. Next slide, please. So this is a patient with ambulatory blood pressure monitoring. You'll see that their average was 143/91. This is a corrected average. And you can see that they have a typical nocturnal dipping that we would see. So this patient does have stage 1 hypertension. Next slide, please. What is important to recognize that if you are using ambulatory blood pressure monitoring, patients who do not have a significant nighttime dip seem to be at an increased risk of stroke and acute coronary syndromes. So these patients, I would be ensuring that I'm managing aggressively. So I would always look at the daytime and evening readings and average them out. Next slide, please. I would do an ECG, and as you can see, this patient certainly has left ventricular hypertrophy. They have, on the right hand, the lateral leads, you'll see ST depression, very high S waves. Next slide, please. And as I've already said, they have left ventricular strain with ST depression and inverted T waves infralaterally, and this is also a poor prognostic sign. This usually is present in patients with significant hypertension or hypertension that's long-standing. Next slide, please. So the LVH voltage criteria, so we would see an R wave in V5 or V6 of over 25, S wave in V1 or V2 of over 25. If we use the Sokolov criteria, then adding those, giving you a measurement of 35 millimeters of mercury, they have LVH. Be cautious in young, thin, athletic individuals who may have LVH criteria, but do not have this on echocardiography. But what we do know is that ECG LVH strongly correlates with development of heart failure later, with a 14-fold increase in patients over 65. And we can negate that by aggressively managing the blood pressure to targets, in my opinion, of certainly less than 135/85, ideally 130/80. Next slide, please. So how do we then treat hypertension? Well, anyone with stage 1 hypertension under 80, we would definitely treat. Over 80, we would treat if they are chronologically fit, if they want to have treatment, but the guidelines say we should definitely treat if they have target organ damage, that includes LVH, CKD, if they have established cardiovascular disease, diabetes, or using the Q-RISK-2 cardiovascular risk assessment score, a score of 10% or over. We would treat stage 2 and stage 3 at any age, and we should offer lifestyle for all. Next slide, please. Younger patients under 40 without target organ damage, CVD, renal disease, or diabetes, I would treat, but I would consider referring to look for secondary causes. Next slide, please. And I've summarized these on the next slide. So primary or secondary hyperaldosteronism with a resistant to treatment plus a low potassium, a good response to spironolactone. We can arrange a renin-aldosterone ratio, and if that's high, they probably have hyperaldosteronism, and possibly arrange a CT scan, which would also help us to look for phacochromocytoma. Other conditions, renal artery stenosis, often where the renal function rapidly deteriorates if you put them on an ACE or an ARB. Cushing's syndrome, aortic coarctation in younger patients. I recently picked up in a patient, a girl of 22, coming in for a pill check where there was significant difference in blood pressure in both arms. And we mustn't forget obesity and obstructive sleep apnea. Refer these to either a nephrologist who does a hypertension clinic, a cardiologist, or a blood pressure specialist, whoever you have. So next slide, please. So the monitoring targets for patients under 80, we would say a clinic blood pressure of 140/90 or a home blood pressure of 135/85. Patients over 80, we would say 150/90 or home blood pressure monitoring of 145/85. Always look for postural hypotension, a significant drop of over 20 millimeters of mercury systolically or 10 millimeters of mercury diastolically can indicate postural hypertension. And in those patients, I would actually use their standing blood pressure to monitor them. Next slide, please. Severe hypertension, those with a blood pressure of 180/20, if they have retinal hemorrhage, papilledema, life-threatening symptoms, so confusion, chest pain, heart failure, or new renal failure, I would send them in for specialist assessment immediately. But if they have no signs, I would arrange urgent treatment, investigation, and review within 7 days. Next slide, please. These are the British Hypertension Society guidelines. I am very happy to share my slides. Noor, I'm happy for you to send these to all the participants. And these are I've already gone through the diagnostic criteria. Next slide, please. For management, what we say is that hypertension with type 2 diabetes, we would start with an ACE or ARB. If blood pressure is not controlled, and a calcium channel blocker like amlodipine or a thiazide diuretic. And step 3, we would use all 3 drugs. In patients under 55 and not Black or Afro-Caribbean, we would use an ACE. In all others, we would use a calcium channel blocker first, and again, work up to triple therapy. For resistant hypertension, that's stage 4, I actually think low-dose spironolactone, if the blood potassium is less than 4.5, is the best drug, using 12.5 or 25 milligrams, and we can use an alpha or a beta blocker. Next slide, please. So I'm just going to summarize here. If you have availability of ambulatory home blood pressure monitoring, use it. Check your blood pressure readings are correct, because you're then giving someone medication, which they will be on life unless they are incredibly overweight or very stressed at the time, and you may be able to bring them off it later. Check compliance, maximize medication, making sure that the elderly, you don't make hypotensive, fall and fracture their hip, refer those under 40 and with severe hypertension, and consider referring uncontrolled blood pressure despite 3 drugs. Next slide, please. So I'm going to quickly move on to angina. What I think we've got to remember with angina is that it is actually diagnosed on history. If you take a very good history, someone with constricting tightness in the front of their chest, often going into their neck, sometimes into the shoulders, and especially if it's going into the neck or jaws, and down the left or sometimes the right arm, if it's brought on by physical exertion or stress, and if it's relieved by rest or GTN within 5 minutes, that is typical angina. This applies to men and women. If the pain lasts for more than 15 minutes, occurring at rest, the patient should be assessed urgently and transferred to secondary care to exclude acute coronary syndrome, especially if it's associated with dizziness, sweating, pallor, or breathlessness. Next slide, please. Factors which make angina unlikely are someone who comes in and says, I've got a constant chest pain, I've had it for days, it's not going away. Think then about things like musculoskeletal pain, reflux esophagitis, heartburn. Chest pain unrelated to exercise, although I would warn that some patients, especially if they get very stressed at rest, can get angina. Worse on inspiration, then think about things like pleurisy, about pulmonary embolism or infarction. And if it's associated with dysphagia, the patient should be referred urgently for endoscopy. Next slide, please. These are the common risk factors. So I like to think of them as the A, B, C, D, E, F, G. C is 2 of them. So advancing age, high blood pressure, smoking, high cholesterol, diabetes, South Asian ethnicity and Afro-Caribbean ethnicity, a family history and familial hypercholesterolemia, and patients with a low EGFR or CKD are all at increased risk of developing angina. Next slide, please. Which blood tests would I do? Well, it's important to not miss a significant anemia, which can cause anginal type pain. I would obviously always check their lipids, their renal function, make sure they're not diabetic. We use HbA1c here. You can also use fasting blood sugar if required. Test to make sure that there aren't conditions like hyperthyroidism, so I would also check that. I don't know if you have access to troponin T or troponin I in Yemen, but over here we use it as a screen for cardiac muscle damage. We do not recommend it in primary care because it may not rise for 4 hours. The more sensitive, the older test, troponin T, was 12 hours, troponin I is 4 hours, and we are getting high sensitivity troponins, which may rise within 30 minutes. But if in doubt, refer to secondary care. Next slide, please. I would always arrange an ECG. A normal ECG, however, does not rule out significant coronary disease. But if they have T-wave changes, ST changes, left ventricular hypertrophy, possibly a previous infarct, then it makes ischemic heart disease more likely. And we should arrange that and make sure that you're competent at interpreting it. If you're not, then ask for advice. either from a colleague or from a secondary care physician. Next slide, please. What we then do in the UK is we use CT calcium scoring. If CT calcium score is 0 and the patient is unlikely to have anginal pain, we use the Duke score, which I haven't put in here because of time, but I'm very happy to send a much bigger slide deck to you after this NUR to send to your colleagues. If the CT calcium score is raised, offer CT angiography. If it's over 400, we would actually recommend going straight to angiography, so invasive coronary angiography. We may use other non-invasive functional imaging in patients who have a medium or high risk of coronary artery disease. And I'll show you what those are in the next slide. So next slide, please. So next slide, please. Thank you. So sorry, go back again, sorry. Apologies, yeah. So what we can do is we can use myocardial perfusion scanning, CT. We are now using more MRI with stress-induced wall motion abnormalities and stress echocardiography. So we can use these to determine whether someone has inducible ischemia. And if it's inducible and recovers after the stress, then the patient may benefit from coronary perfusion procedures. Next slide, please. So how do we manage angina? Then I would always try to start with a cardioselective beta blocker. And the one that we tend to use over here is bisoprolol. Sometimes we use nebivolol, metoprolol, or carvedilolol. We rarely use atenolol now. If beta blockers, cardioselective ones, are tolerated by most patients with COPD and even asthma, if they are, however, contraindicated, I would use a rate-limiting calcium channel blocker, such as diltiazem or verapamil. If the patient isn't controlled, then you can use these together, but I would never use a beta blocker and a rate-limiting calcium channel blocker. At that stage, I would switch to amlodipine, lercanidipine, lacidipine, because using a rate-limiting calcium channel blocker and a rate-limiting beta blocker, you can push the patient into heart block. What the guidelines now say is that if angina is not controlled on 2 agents, you should refer that patient for assessment and only add in a 3rd drug if the patient does not want to have any revascularization or further investigation. And there you can use things like isosorboid mononitrate, nicorandil, ivabradine are 3 of the other drugs we sometimes use. So next slide, please. So I'm just going to summarize chest pain before I move on to heart failure. Just to say the majority of people who present to you with chest pain in primary care don't have angina. And the main thing is to take a very good history, to look for the character of the pain, radiation, etc. Blood tests may help you to identify causes such as anemia, renal disease, hyperthyroidism. I would always do an ECG, and I think all people with suspected angina should be referred to a cardiologist for further assessment. Next slide, please. So breathlessness, is it heart failure? Where Hassan, one of my Bangladeshi patients, presented. He was 76, shortness of breath on exertion. We used the New York Heart Association classification, where one is no symptoms. So people with LVSD, left ventricular systolic dysfunction, may have no symptoms. NYHA class 2 is when they get short of breath going up an incline or steep stairs. NYHA class 3 is if they get it on the flat, and NYHA class 4 is if they get it shortness of breath at rest. He had ankle swelling, orthopnea, he was sleeping with 3 pillows. He'd previously had an MI, so was already on some medications. When we examined him, he had pitting edema, his blood pressure was good, pulse was regular, he had some bibasal creps, and JVP was up 4 centimeters. He did have a pansystolic murmur, intensity 2/6 along the left sternal edge, and good oxygen sats. We should always think heart failure in patients, especially if they have a history of MI, those with atrial fibrillation, patients who keep coming back saying, I've got, coughing up phlegm, ask about it. Is it frothy? Is it bloodstained? Does it wake them at night? And has it just been put down to a chest infection? Always think about it. Diabetes and hypertension. Next slide, please. Diagnostic features, shortness of breath on exertion. The most sensitive and specific are orthopnea. So if a patient lies flat in bed, they wake up, gasping for their breath, coughing up frothy sputum, which is paroxysmal nocturnal dyspnea, then they're very likely to have pulmonary edema and therefore likely to have heart failure. Things like decreased exercise tolerance, peripheral edema. In older patients who are not very mobile, think about it if they're confused, altered mental state, or very fatigued. The signs to look out for, obviously peripheral and pulmonary edema, a raised JVP, a third heart sound, which you usually get if someone's in pulmonary edema or significant heart failure, and later on you may get displaced apex if they have cardiomegaly, ascites, often with hepatic engorgement. Next slide, please. Heart failure, the priority is to identify left ventricular systolic dysfunction, commonly caused by scarring from a heart attack, because we have a big evidence base for medications in those groups to improve the prognosis. We should always arrange an echocardiogram if we suspect it. Think about drugs that may exacerbate or make heart failure symptoms worse, such as rate-limiting calcium channel blockers and anti-inflammatory drugs. Remember that things like Herceptin chemotherapy for breast cancer and other chemotherapies can trigger heart failure, and these patients should have routine echocardiography. And also remember that the diagnostic accuracy of examination, especially JVP, lung signs, and third heart sound even, are poor. So what tests should we arrange? Next slide, please. So we should definitely, I believe, do a chest X-ray, ECG, test the urine, think about spirometry and pulmonary function tests, especially if they're a smoker, and do the usual renal, thyroid, liver, lipid, HbA1c, and fluid blood count. But the most important test is, next slide, please. And I'm not sure if you have access to natriuretic peptides in Yemen, but NT-proBNP is nearly always raised if a patient has heart failure, and those raised NT-proBNP should go for echocardiogram. Next slide, please. And what are natriuretic peptides? Well, proBNP is an inactive protein that sits in the cardiac myocytes. When the heart comes under strain because of afterload or preload, it gets cleaved to the inactive moiety, which is N-terminal proBNP, and the active moiety, which is BNP. Next slide, please. And what we know is that the heart and the body does this because BMP suppresses the renin-angiotensin and endothelial systems. It decreases peripheral vascular resistance, decreasing blood pressure, but most importantly, increases natriuresis and diuresis. So it tries to compensate for the heart being overloaded and overstressed. And it's raised in left ventricular systolic and diastolic dysfunction, valvular dysfunction, so severe aortic or mitral regurgitation. Next slide, please. Remember that raised NT-proBNP does not mean heart failure. It can also be raised in acute kidney injury, significant coronary kidney disease, hypertension with left ventricular hypertrophy, recent or previous MI, atrial fibrillation, and also pulmonary disease, especially if it causes pulmonary embolism, infarction, or pulmonary hypertension. NT-proBNP goes up with age, and we use age-related cutoffs in some areas. It's slightly higher within females, and it can also be raised with hyperthyroidism, sepsis, chemotherapy, but it can be lowered with significant obesity with a BMI of over 40, and rarely with other conditions such as mitral stenosis and HOCM when they're on treatment. Next slide, please. So what the NICE guidelines say for diagnosing heart failure in the UK are take a detailed history, perform a clinical exam, check NT-proBNP. If NT-proBNP is less than 400, heart failure is unlikely, and you should look for another cause for the patient's symptoms. So that's on the right-hand side. If it's over 2,000, then patients should be referred urgently for specialist clinic assessment, including echocardiography. In the UK, we try and specify within 2 weeks. If it's moderate, 4 to 2,000, we suggest refer within 6 weeks. And then they should have tests. If the heart failure is confirmed, we should assess the severity, look for the etiology, precipitating and correctable factors, and decide whether the patient has heart failure with reduced or preserved ejection fraction or any other cardiac abnormality. Next slide, please. And this is the algorithm for managing it. I know it's rather busy. Again, you can have this afterwards. So we would offer diuretics if they have congestive symptoms, furosemide or bumetanide. Patients with reduced ejection fraction should have an ACE or an ARB if they develop symptoms such as a cough, which 1 in 10 do. A licensed beta blocker, which means bisoprolol, nebivolol, metoprolol, or carvedilol. And if they're still symptomatic, a mineralocorticoid antagonist, which is spironolactone or eplerenone. If patients are still symptomatic, we can consider them for sacubitril valsartan or Entresto in this country. If their ejection fraction is less than 35%, we may use ivabradine for those in sinus rhythm and a heart rate of over 75. Rarely we use hydralazine and nitrates, especially in Afro-Caribbean patients. And occasionally we would use cardiac resynchronization or implantable cardiac defibrillators. HFpEF, there are no drugs that alter mortality, so we should manage their hypertension and atrial fibrillation. Next slide, please. So a summary for heart failure, again, take a good history, look at the past medical history. If they've had an MI, if they have atrial fibrillation, if they have coronary heart disease, look for potential causes, use NT-proBNP if you have it. Next slide, please. So I'm just going to finish off with atrial fibrillation, a condition that we are seeing more and more in the UK as people live longer. So on the left-hand side, you've got the normal electrical activity of the heart. The heart's pacemaker. Metronome is a sinus node. It sends a regular signal through the atrioventricular node, which is almost like the brake of the heart. And that then goes down the bundle of His, left bundle, right bundle. You also have some normal electrical activity going across the heart to the left atrium. But what happens in atrial fibrillation is you get these abnormal electrical pathways, wavelets as we call them, and that means that you lose the atrial kick and you lose the P wave on the ECG. With the AV node still functioning, because with atrial fibrillation you can get rates of around 300 in the atria, you need a good functioning AV node to filter that out and reduce the rate hitting the left ventricle. Next slide, please. Symptoms of AF, well, up to 40% of patients are asymptomatic. And because of that, I always check a pulse of a patient over 65 with other comorbidities coming into my clinic. Some patients may experience palpitations, occasionally fatigue, chest pain, dizziness or lightheadedness, rarely syncope, and sometimes exertional dyspnea. Next slide, please. So this is what you typically see on an ECG. So an irregularly irregular pulse, so a pulse where the rate is irregular, the character is irregular. So while you're taking it, you may feel some more forceful and some weaker pulses. Think about atrial fibrillation, and you'll see from the ECG, the P waves are replaced by these fibrillatory waves. Next slide, please. And this is a normal ECG. Next, just click the slide, please. And again, please. So, and again. Sorry, yeah, go back. Apologies. Actually, just leave it. So what I would say is you saw those last two ECGs were typical atrial fibrillation. Look for it in lead 2 or V1 or V2 where you'll see it. Always think about atrial flutter, especially if you have a heart rate of over 120 and regular. This patient had atrial flutter. You can see these beautiful atrial flutter waves in this rhythm strip, which is strip 2 at the bottom, and they have a 4:1 AV conduction. The patient also had a degree of left ventricular hypertrophy with repolarization and had previously had an inferior infarct. Next slide, please. What we do know about atrial fibrillation is that some patients start with paroxysmal atrial fibrillation where it comes and goes. AF tends to progress with structural changes in the atria, which include electrical contractile changes known as atrial remodeling. You can then go into persistent, long-standing, then permanent atrial fibrillation. Next slide, please. Which patients do we opt for rate control or rhythm control? So if a patient is very symptomatic, they're younger, they present for the first time with low atrial fibrillation, secondary to a treated or correctable precipitant, such as hyperthyroidism, alcohol abuse, or those where atrial fibrillation may be making the congestive heart failure worse, we would refer them for consideration of initially direct current cardioversion or ablation therapy. Because most patients, once they've had DC cardioversion, up to 90% go back into atrial fibrillation at a year, those over 65, those with coronary artery disease, Those with contraindications to drugs like amiodarone, which we might use for pharmacological cardioversion, or those unsuitable, we would just opt for rate control, usually using a cardioselective beta blocker or a rate-limiting calcium channel blocker. Next slide, please. But the real importance of atrial fibrillation is stroke. Unfortunately, strokes that occur in patients with atrial fibrillation are often far worse than those that occur in patients without atrial fibrillation. Why do we think that is? Well, because thrombus tends to build up in the left atrium, as you'll see on the right here, usually in the left atrial appendage. It embolizes from there through the aortic valve, up the wide bore common carotid artery, the equally wide bore internal carotid artery, and a large clot hitting the brain can cause either a catastrophic fatal stroke or a very disabling stroke. Next slide, please. So what do we have to do? We have to assess these patients. We use the CHADS-2 VASC score, and we also assess the bleeding risk using the HAS-BLED score. And these are the NICE algorithms. Patients who have a CHADS-VASC of 0 if men or 1 if they're women, because women only have an increased risk if they get to 2 with additive risk factors, then no antithrombotic therapy is needed. In men with a score of 1, then we should consider oral anticoagulation, and all patients with a score of 2, we should offer either vitamin K antagonists, which is warfarin or coumarin or acenocumarol, or one of the non-vitamin K direct oral anticoagulants, apixaban, dabigatran, edoxaban, or rivaroxaban. If warfarin control is poor, we should consider switching to a direct oral anticoagulant. There are very few patients that are truly contraindicated or intolerant, where we can use a left atrial appendage occlusion device, like a little umbrella, sits over the left atrial appendage, introduced transfemorally or transradially, and it reduces clot embolysis. Next slide, please. So why do we use the newer novel or direct anticoagulants more? I'm not going to go through all the slides, but this Christian Rough meta-analysis shows, looking at all 4 DOACs versus warfarin, that they reduce stroke and systemic embolism overall by 19%, significantly reduce intracranial hemorrhage. And whilst they may increase GI bleeding, they actually reduce the risk of major or fatal bleeding. Next slide, please. So the relative safety. What we need to do is adjust the dose of these drugs. And this is a chart we have in all our consulting rooms. So whichever drug we use, by looking at things like creatinine clearance, eGFR is not good enough. With other drugs, so that's all you need for rivaroxaban, and that's my favorite drug. Edoxaban is my second favorite drug because they're the easiest to dose adjust. You will need things like weight, age, serum creatinine, and whether they're on potent PGP inhibitor drugs like rifampicin, carbamazepine, clarithromycin, etc. So again, happy to send this over to you. Next slide, please. I think we're coming to the end, Noor. So this is the last slide. So who should we refer to as specialists? Well, I believe patients with atrial fibrillation who are older, who are not very symptomatic, we can either rate control and treat in primary care with oral anticoagulants. But we should refer younger patients, those whom pharmacological therapy has failed, and obviously if they have worrying things like Wolff-Parkinson-White syndrome or atrial flutter, we should refer all these patients. So thank you very much. I know that was a whistle-stop tour. Apologies for the delay in getting it started, but I hope you enjoyed it. And I promise I will send I've got a much bigger slide deck on cardiac investigations. If I send that to Mobasar or Noor, and very happy for you to forward that to your colleagues, Noor.
No, thank you very much. Very insightful talk, Professor Ahmed. Thank you very much for your time. Really do appreciate it. We got there in the end. We do have a few questions, if you don't mind, just hanging fire for the next 5 to 10 minutes.
No problem.
Brilliant. So first question is, ECGs are difficult for lots of doctors. How can we get better at this?
Oh, God, right. That's a question, isn't it? I think have a system. Have a system on how you approach it. So start with looking, what is the rate? Is it regular? Look at then the P wave, QRS complex, T wave, etc. There are lots of courses available, and we will be putting up a video of ECG interpretation on the PCCS website in the next couple of months, which people can access. And they're not easy. Sometimes they're difficult even for people like me. So, and I'm not a cardiologist, I'm a GP with a specialist interest. But if you are unsure, then like we do over here, we often email an ECG to a cardiologist, say, will you please advise? So unfortunately, it's not, I can't teach you how to interpret an ECG in a couple of minutes, but there are tools out there. There is a site you can, which doesn't cost very much either, which is, I think, called Agapadoodle, which is very good too. But, feel free to join the PCCS and look out for resources.
Brilliant, thank you. So our next question is, family doctors in Yemen. We are seeing lots more coronary artery diseases. Apart from blood pressure control, what is the best things we can do that is cheap and does not need much monitoring?
Yeah, so those with coronary artery disease, I think the things you need to do are mainly lifestyle. If they smoke, you need to stop them smoking. I forget what you call them, but the shishas, a shisha has the equivalent of 100 cigarettes in one hit. And, I think that we should be discouraging that, as, especially in, countries like Turkey and Cyprus, where I'm from, they're used a lot too. So stopping smoking, minimizing alcohol intake, so less than 14 units. I appreciate many of your populations are Muslim and don't drink at all. The good Muslims, of course, not ones like me who does drink now and again. That we should make sure that we get their blood pressure adequately controlled. Their cholesterol is very important. If they have coronary artery disease and hyperlipidemia, I would be looking to get their low density lipoprotein below 1.6, or at least their total cholesterol below 4. So I think they're all the cheap and easy things that a family practitioner can make a difference with. And then obviously to control their symptoms, use drugs like beta blockers, rate limiting calcium channel blockers, as I outlined, to help their quality of life. Explain to them to perhaps use their GTN spray before they go out. A good tip is some people get really bad headaches and dizziness and lightheadedness with the spray or under the tongue GTN. If you're using a spray, if you just spray it onto here, the web of your hand, and lick a couple of times, they can get enough without getting the big hit that gives them a headache. I hope that answers that, Noor.
Yes, I'd hope so. So PCI for STEMI might be too expensive. Sometimes the patient will not be able to get to the centre quickly, like if they're living in the village. Should a family doctor do the thrombosis in the clinic if it is far away, or do the PCI if the patient and the family cannot afford the money for the PCI?
Well, yeah, I mean, it's down to affordability, and it's also down to experience. You know, certainly in the UK, before we set up all these cath labs, which every area has, and still actually in some of our remote geographical areas, like the Highlands of Scotland, etc., ambulance crews and GPs do administer thrombolysis. So if you are skilled enough, if you've got the diagnosis right, and the patient can't get to a center or can't afford to get to a center, thrombolysis is better than nothing at all. And the earlier you do it, the better, because that minimizes the persisting muscle damage that that patient may experience.
Okay, thank you. So next question is, dear Professor Ahmed, thank you for the talk. Can NT-proBNP be expensive for a lab test? Can we use something else for heart failure, or is the BNP very much higher in the heart failure than with other conditions like pulmonary disease or AKI?
Right, okay. The reality is that NT-proBNP is the only good cardiac marker that has the best negative predictive value. So you can exclude heart failure by using NT-proBNP. I appreciate it might not be available to you guys, but unfortunately there's no other blood test that gives you that. So I then would say that if they have symptoms and signs that you think are heart failure, especially if they have an abnormal ECG, they should be referred for cardiac ultrasound or echocardiography to determine whether or not they have heart failure with reduced ejection fraction, which you can then treat in the community with ACE or ARBs, beta blockers, and drugs like spironolactone. And generally, yes, heart failure with reduced ejection fraction does tend to cause much higher NT-proBNP levels than with pulmonary disease or acute kidney injury. So it's a difficult one if you don't have it available.
Okay, so next question is, what kind of cases should I start treating as a family physician without actually referring to a cardiologist?
Well, I hope I showed that in this.
Yes.
I think hypertension you can definitely manage. Even patients under 40, if you have the tests available, obviously we do in the UK, we can do a chest X-ray for coarctation. We can arrange an MRI to check for pheochromocytoma of the adrenals. We can do things like renin-angiotensin ratios. But if you don't have them and a patient's under 40 and they have very high blood pressure, you should refer. You can manage most atrial fibrillation in the community. The main thing is to get them on a stroke preventative agent and get the rate control. Angina, I think you can manage in the community with GTN, with beta blockers, etc., if the patient can't afford to or doesn't want to go for further investigation. So I think all these things can be managed in the community by a skilled family physician.
Brilliant. And our last question before we break up for break. Is the Middle Eastern, like Yemen, shall I say, higher risk for coronary artery disease?
Well, I'm not a Middle East expert. I now practice in the UK. But you know, I think coronary artery disease is certainly high in many countries like Turkey and Egypt, I certainly know about, largely due to smoking, which a lot of people still do, sometimes hereditary familial hypercholesterolemia, because that risk is increased, especially with intermarriage. So if people are marrying first cousins, etc., someone has the gene for familial hypercholesterolemia, then that can increase the risk of developing homozygous FH, which can cause early coronary artery disease. So I guess the answer is yes, I think much of the Middle East has high coronary artery disease. I'm sorry, I don't know what it's like in Yemen. And I tried to Google some stuff beforehand, but couldn't find a great deal. But I think that was the last question, wasn't it?
Yes, it was. Yes, it was. A big thank you for giving up your time today. We really do appreciate for a very insightful and enjoyable presentation. So thanks again from all of the attendees and also from the INTERYem organisers, Dr. Wahib and Dr. Mubashir.
Thank you very much. Thank you for
Brilliant.
asking. I'm more than happy to come back and give further talks and happy to support you guys. So
brilliant.
Take care,
Thank you.
everyone, and have a lovely day.
Thank you. We shall break up now for half an hour, and our next talk would be Professor David Misselbrook, which is on medical ethics and the family physician. So see everyone back in 30 minutes. Thank you.
Hello, it's David Misselbrook here. I'm just seeing if my slides will work, and if so, then I'll log off from screen sharing until everyone is ready to start.
Hi, David. Your slides are working well. Thank you.
That's great. It looks like it. Thank you very much.
We'll just pause for a few minutes until people come back to the break, if that's okay.
I'm in your hands until you're ready to start.
Can everybody hear me? Okay, so we're nearly there to start our last session. Okay, hello again. My name is Wahib. I'm one of the project coordinators for INTERYem. We are now live for our last session for the Family Medicine Conference, which spanned over the last 2 days. Our speaker Can you hear me now? Okay. So our guest speaker now is Professor David Misselbrook. He will be talking to us about medical ethics and the family physician. So I'll briefly introduce Professor Misselbrook. He's trained in London, trained as a family physician. But then he built his own healthcare center from single-handed practice to a 5-consultant and 2 residents teaching and a training practice, with a full primary healthcare team and a wide range of additional services. He has wide experience of leadership in service development, governance, and medical education. He was involved in development family physician training in South London. He was previously the Dean of the Royal Society of Medicine in London and was involved with the postgraduate educational planning and evaluation. He was a member of the directors for continuing professional development committee of the Academy of Medical Royal College, and thus centrally involved with the regulation and development of the UK CPD. So apologies, there seems to be an echo, which I think we can address with this. Okay, is this better now? Okay, apologies. And also to add, Professor Misselbrook has extensive experience of the Middle East situation. He was in Bahrain for some time. He was the Associate Professor of Family Medicine from the Royal College of Surgeons Island in Bahrain. He was the convener for the Research Ethics Committee and the chair of the School of Medicine Academic Committee. He was the RCSI representative on the National Health Regulatory Authority CPD Committee of Bahrain and was a member of the Bahrain Ministry of Health Internship Committee. He's now Senior Ethics Advisor and the Deputy Editor of the British Journal of General Practice and sits on the Curriculum Development Committee of 2 medical schools. Without further ado, let me welcome Professor Misselbrook to give his keynote lecture. Please see if you can share your screen with us.
Thank you so much, Dr. Wahib. And thank you to INTERYem for the honor of asking me to speak to you. Salam alaikum, my colleagues in Yemen. It is a very great pleasure to be speaking to you today. And I do hope that this conference demonstrates that doctors are brothers and sisters all around the world. And there are many, many physicians all around the world who are thinking of you at this time. And we're all hoping and praying that the end of your troubles will
comes soon, and there will be many people who will be happy to try and help rebuild your country's healthcare system. And as we've learned from earlier lectures, an absolutely crucial and central part of that healthcare system, if it is to work well, will be primary care and family medicine. So thank you for your patience in listening to me the last thing on this Sunday afternoon. And I want to talk to you about medical ethics and the family physician. So I bring my greetings from the Royal College of Surgeons in Ireland, Bahrain, where I spent 6 very, very happy years teaching. I confess this wasn't actually our staff canteen. This was sort of a special occasion. And my wife and myself have come to love the Middle East very dearly, and my work took me around the 6 GCC countries, although I regret I never came to your own country of Yemen. And now I'm back in my own home city of London, and that's one of my morning walks in Greenwich Park, looking down over the park and some old buildings and into one of the central areas of London. So a lot more cloud. So I've been asked to talk to you today about medical ethics, in particular about the so-called 4-principle model of medical ethics, and to try and use that model to apply to some very specific situations in family medicine. So the aim of this session is to enable us as colleagues to use the ethical principles of beneficence, non-maleficence, justice, and respect for autonomy in specific challenging professional practice situations. So where does this start? Well, it starts with a very simple observation, and that is that there is something very remarkable and special about being human. All humans have an inherent dignity. As humans, we also have the ability to reason, we have freedom, free will, if you like, and we have the ability to relate together within communities. And it is this that forms the heart of why we need to deal with one another in an ethical and moral way. So as doctors, we're particularly privileged to be at the center of that issue of dealing with other human beings rightly. And therefore, as doctors, we know that we and our patients are not machines made of clockwork. There is something very, very special about what it is to be human. And as doctors, it is very helpful if we use models such as the biopsychosocial model. So doctors need to see the whole picture, and doctors need to deal with the whole picture. Seems to me that very often in our training, we're trained to deal with the biological part of that model, the biomedical part of that model, and perhaps with issues of mental health as well. But it's for us as family physicians to try and put the whole model together with the psychological side of what it is to be human and humans in our communities. Family medicine, after all, and the notion of primary care talks about what it is to be a doctor, not just to a bit of a person, their leg or their kidney or their heart, but to be a doctor to a whole person with their thoughts and feelings and beliefs within their community. And it's this sort of doctor that we want to be as family physicians. So the great physician Ibn Sina said, it is said that some parts of medicine are theoretical and other parts are practical. This does not mean that one part teaches medicine, the other puts it into practice. No, the intention is something else. It's that both parts of medicine are science, but one part is the science dealing with the principles of medicine, and the other is how to put the principles into practice. And so it seems to me, it's very, very clear that medicine needs both of these aspects, both facts and values, in fact. And that is what we shall be talking about. So let's start at the beginning. How do we determine what is right? Well, there are 2 basic approaches. One is to start from the top down, as it were, and the other is to start at the grassroots. it would be a different lecture and a very, very interesting one to talk about moral theory. And I think you could teach me as much as I can teach you about moral theory. But what I'm going to do today is to do something much more modest, and that is look at a checklist approach to medical ethics. Moral theory has indeed been developed over the last couple of thousand years, particularly within the Abrahamic traditions and also in the West, adding on issues of learning after the Enlightenment and so on. And we need to bring these together. But actually, you don't always need that sort of fundamental theoretical approach to tackle practical problems, because all of us as human beings have a moral sense in our hearts and our minds. And when you look at the East or the West, the interesting thing is that moral sense comes up with very, very similar conclusions. So what I want to do today is to tackle it more from the point of view of a checklist approach. And the particular checklist I've been asked to talk about is that of principlism, or the four principles, the four principle approach: respect for autonomy, doing good, not doing harm, and acting justly, and also remembering the issue of scope. And of course, the Islamic tradition also has what one could regard as a checklist. That is, what is the intention or goal of an action? Are there any certainties about the outcome of an action? Might harm arise from the action? Will the action relieve hardship? Is the action according to or against established custom? And this last one, I understand from my scholastic friends, doesn't mean that you can't do anything new, but rather if you are seeking to do something that is not in line with established custom, you should stop and think and then analyze and debate why you believe that to be right. And I must admit, my personal view is that these traditional questions form an extremely good and helpful checklist. But if we look at world medicine in general, principlism is very commonly used, and that's what I will be talking about today. So principlism comes from a work of two ethicists, Beecham and Childress, and in their book, which is a very interesting book, well worth reading, they bring out these four principles: respect for autonomy, beneficence, which is just a posh word for doing good, non-maleficence, which is just a posh word for not doing harm, and justice. And one of the points they make is wherever you are in the world, all of us can agree that these indeed are four principles that all of us believe are good for medical practice. And of course, two of these principles come directly from the Hippocratic Oath. So within the Hippocratic Oath, you have this famous paragraph: I will prescribe regimens for the good of my patients, according to my ability and my judgment. And so I'm going to go through these principles one by one and looking at some of the issues that arise from them. So the first question, what is it then to do good? Well, we know from the Islamic tradition that from the Holy Quran, it says, whoever saves a life, it will be as if they saved all of humanity. And of course, this is part of our core duty as doctors, that we want to save lives, but not just to save lives, to save health as well. So this is clearly a core part of what it is to do good. And indeed, we can look at other traditional aspects of what it means to do good. So doing good relates to the proper goals of action for doctors, human welfare including. So you'll notice that these four lines are four of the five traditional proper goals for action within Islam. These are the four out of the five that relate specifically to the duties of a doctor. So these duties are the preservation of life, the preservation of the mind and intellect, the preservation of property, which I would suggest includes bodily health, that is our property, and the preservation, of course, of children and the family line. So all these actions we can instinctively see are very much part of the call of what it is to be a doctor. But another thing, if we want to do good, we need to ask the question, what causes the most death? And according to the University of Washington, this slide relates specifically to Yemen, although I cannot guarantee exactly how up to date it is. But this slide relates to Yemen. And according to this slide, the #1 killer in 2019 was ischemic heart disease. #3, stroke. #9, hypertensive heart disease. #11, chronic obstructive pulmonary disease. So these are diseases that can be controlled both by lifestyle measures and by chronic disease management. So it's very interesting that as soon as we ask ourselves the question, what is it to do good? When we ask that question seriously, in the proper tradition, then we're immediately alerted not just to acute illness, which is very obvious to see. Patients will come to us, patients will bring their children to us. We can see acute illness or acute injuries. Those needs are obvious, but we need to ask ourselves the question, how can we do most good? And part of doing most good is not just attending to the people who are brought to us, but actually trying to create structures of care for people with chronic diseases and chronic disease management and prevention of illness. So this is an ethical issue of how we can do most good. Therefore, all of what has been talked about by some of the previous speakers has an ethical dimension to it as well. Another aspect that is very important as to how we do good is to look at the whole person, the whole picture. I've already said that as doctors, we're often trained just to look at the biological bit of the person. But people are one whole unit. We can't really divide us up. Humans have a unified nature. Any one part will affect the whole. So if people are under social and environmental pressures, and of course, tragically, we know that that includes war. If people are under psychological pressures of need, of the worry about providing for their family, about anxieties for their family's well-being, then all of these may also present as somatic symptoms. There are many, many somatic symptoms, such as pains that we can't put a specific diagnosis on, abdominal pains, headaches, worries, many, many different symptoms. Sometimes these are called medically unexplained symptoms. And medically unexplained symptoms tends to be either our psychological or our psychosocial aspects of our body actually leaching through, if you like, into our body itself, causing us to feel physically unwell. And family physicians are in the best possible place to understand this and to try to work with patients with these sort of symptoms to help them to understand where their symptoms are coming from. These are the typical symptoms that would appear in the UK in the heading of medically unexplained symptoms: low back pain, chronic fatigue, irritable bowel, chemical sensitivities, so-called fibromyalgia, anxiety, headaches, post-traumatic stress disorder, panic attacks. So these would be so-called medically unexplained symptoms, or produce medically unexplained symptoms. I'm well aware that the situation in Yemen is very different, and you will have both your own stresses and your own clusters of symptoms that can't be explained by simple medical means. And again, as family physicians, we want to do good. And part of doing good is trying to help patients to understand where these symptoms are coming from and to bear with them and help them to interpret what they mean. I would suggest that there are 4 basic functions of the family physician. Biomedical therapist, that's the bit we're best trained at. That's the best bit usually that we're good at. We're called also to be leaders in our communities, to lead our communities to better health. We're called to be sickness guides to our patients, advising them how to maximize their strength and their being for the sake of their own health and their families. Some of this, of course, is lifestyle advice, as was mentioned in the last talk, for example, giving up smoking, which is very difficult to do in a stressful environment. But also, and we don't think about this enough, I think, to witness, simply to listen and understand our patients' health and life struggles, to have somebody in authority, such as a doctor, taking our patients seriously and listening to them is a very important intervention in itself. And I realize is a very difficult intervention when we have so little time. We need to understand the whole patient. So doing good. Some of doing good is obvious. Of course we save lives. Of course we try and intervene with acute illness. Some of doing good is less obvious, and I think we need to think on all of these things. So non-maleficence, not doing harm. Again, this comes directly from the Hippocratic Oath. I'll prescribe regimens for the good of my patient according to my ability and my judgment, and never do harm to anyone. Well, of course we don't want to do any harm. We're doctors. Why would we want to do anyone any harm? But of course, harms can come from medical treatment. Therefore, if we want to take this aspect of our ethical duty seriously, we need to consider this as well. Because again, it is a principle. No harm should be inflicted or reciprocated. Harm must be rejected. This is a moral principle, not just an ethical principle. So as doctors, we need to assess the risks of treatment. We shouldn't just rush into treatment without considering whether it's right for that individual patient. We need to assess possible side effects of treatments, such as medications. And we need to assess treatment burden. What is treatment burden? I can explain it better in a UK context. Some of my patients, particularly my elderly patients with multimorbidity, many different things wrong with them, were taking many different sets of tablets every day. And perhaps, particularly if they were an elderly couple and always spent their time together supporting one another, they might go up to a hospital appointment 2 or 3 times a week. One for the man, the other for his wife, but they'd both go up to hospital, catching a couple of buses, spending their resources and their time. And the treatments themselves could be a burden. So we need to be very realistic about making sure that the treatment is not as much of a burden as the disease itself. And of course, in most healthcare systems where people have to pay for their treatment, this is especially true. And the other aspect of harm, of course, is patient safety. This is one of the best known models of patient safety, the so-called Swiss cheese model. Swiss cheese has lots of holes in it. They're caused by bubbles when the cheese is fermenting. But if you cut Swiss cheese into slices, you get these square slices of cheese with lots of holes. And the idea is that if you line all the slices up, sometimes things could go right through from one side to the other, or many things, of course, would be stopped where the holes don't line up. And this is a very good way of thinking of the dangers of medicine, because most of what we do have a number of safety barriers built in. I write a prescription. What if I get the dose of the drug wrong because I'm just not thinking clearly that day? Well, hopefully the pharmacist will pick that up. Or hopefully the drug isn't available in this 10 times or 100 times dose that I prescribed. Hopefully, hopefully, hopefully. You see, there are a number of safety measures at each point. But what if something goes wrong with each of those safety measures? So it is up to us as a matter of ethical concern, to do all we can to be diligent, to check, to double check. Drug dosage is one obvious example. Operating on people would be another obvious example, where there's a checklist of things we must check before we even start, to try and reduce as much as possible the risk of anything going wrong. Another way we can do harm is simply by not giving the best or healthiest treatment because we want to always please the patient. So a mother brings a child, doctor, my child has a cough. So there are doctor's health beliefs, patient's health beliefs. The doctor's health beliefs would straight away, I wonder if it's another case of COVID. Oh, or if it's not, well, most coughs are viral, some are bacterial. I need to remember tuberculosis, HIV, etc. But of course, the patient's thoughts are a little bit different. Is it pneumonia? Could it be TB? Is my child really ill? Can I trust the doctor? In most cases, we share enough health beliefs that we can talk openly to one another and come to a shared conclusion. Sometimes that's difficult. Doctor, my child has a cough. He always needs antibiotics. Well, the doctor might think, well, I've checked it out. It's just a viral cough. But the patient may be thinking, my child might be really ill, and can I trust this doctor? Now, if, for example, we always give in to what patients want, then firstly, we're not treating them right. But secondly, we could actually be harming them. Because just in this very trivial but very real everyday example, if we give patients antibiotics repeatedly, they'll get side effects, they're spending money unnecessarily, and they're reducing the likelihood of antibiotic resistance in the community, which would harm the whole community. So how can we react there? This is very difficult. I was a family physician in London for 30 years, so this is a very common scenario. And I would suggest that our job is to try to build a bridge within a long-term relationship of trust. So this is not necessarily something we can fix easily or fix today. Sometimes we need sort of halfway positions. Okay, well, perhaps wait a couple of days and see how your child is. I think you'll find he'll be fine, and I'm happy to see him again in 2 or 3 days if you want me to check him out. Those sort of compromise positions, or, well, I think he's all right at the moment, I'll give you a prescription for some paracetamol, but bring him back if you think he's worse. And sometimes that, I know that isn't possible, but above all, we need not just to reject a patient's concerns, we need to listen to the patient's concerns, because that's the only way we'll ever come to that position of trust and sharing of ideas. So our job is to build a bridge within a long-term relationship of trust. Okay, respect for autonomy. In the English tradition, this gentleman, John Stuart Mill, set this out very clearly in his very famous book on liberty. He says, over himself, over his own body and mind, the individual is sovereign. So that's a very clear statement of autonomy. But of course, as you will know better than I, there are many, many statements of the need to respect autonomy also within the Islamic tradition. And it certainly is the case that every adult has competence to take mubah, permissible decisions relating to their own life, unless there are genuine reasons otherwise. And my personal view is I find this this graded position of things that must be done, things that are better to be done, things that are preferable, things that are permissible, things that usually should not be done, and things that are forbidden. This is actually a very, very helpful sort of scale of understanding what is good and bad that I have introduced in my lectures here in the UK, because I think it is a very helpful understanding, much easier than just saying some things are always right, some things are always wrong, and that's an end of it, because life is complicated, isn't it? Another aspect of the respect for autonomy, of course, is consent. Consent is central to good medical practice. A patient's voluntary agreement to treatment or examination or any other aspect of health care. It's central to good medical practice. It is also a moral requirement. And in every legal jurisdiction that I've become aware of as I've traveled around the world, also quite rightly a legal requirement. The only thing, of course, that we have to check with consent is that the patient has capacity. Obviously, a young child does not have capacity to give or withhold consent. A young child's consent will come from the parents. And there are some individuals, such as those with severe dementia or those with mental illness, and of course, somebody who is brought in unconscious by the ambulance. Well, they don't have capacity to give consent. You must go on and treat them according to their best interests. But you would normally, of course, get consent from a family member. So there are times when we may need to assess capacity, but we should assume that all adult patients have capacity unless there is a reason to believe otherwise. And again, confidentiality comes under the respect for autonomy, because my health is my business and it's not something to be talked about and spread around to other people. All doctors understand the need for confidentiality. And of course, this again comes directly from the Hippocratic Oath. It's a prima facie ethical obligation, unless it conflicts with a stronger obligation, such as these here. It is permissible to disclose without a patient's consent when ordered by a judge in a court of law or an established legal tribunal, when absolutely necessary to protect the interest of the patient, which is unusual, when absolutely necessary to protect the welfare of society, for example, infectious diseases, when absolutely necessary to safeguard the welfare of another individual or patient. For example, if somebody is a threat to another person. The opposite of autonomy is paternalism. And here it gets a bit complicated, because if respect for autonomy is right, surely paternalism is wrong. Well, there are situations where paternalism may be justified. Sometimes, obviously, autonomy is not a possibility. A comatose road traffic accident victim, a pediatric emergency with no parent present, somebody who is acutely psychotic, then we must act in a paternalistic way, but we must also act in the patient's best interest. But also, of course, patients, and in the UK, this is more true with elderly patients, some patients want to put the decision-making process back to the doctor. They don't, not all patients want to take part in a decision-making process. And as long as we do our best to offer them genuine and reasonable choice and say what the options are, then it is fair enough for the patient to say, well, I need you to guide me, doctor. It is legitimate for a patient to be guided, not overruled, in their choice where complex technical decisions are made. Okay, so we've done doing good, not doing harm, autonomy or respect for autonomy, to be more accurate, and let's briefly look at issues of justice. There's a, well, I was going to say there's a hadith, but of course this is quoted in a number of different hadiths. No man is a true believer unless he desires for his brother that which he desires for himself. So justice, this is an example of the so-called golden rule. And it's called the golden rule because words very, very close to these words are present in all of the religious traditions around the world. And it seems to me that there is something in the heart of humanity that is aware of the need for justice. The problem comes that justice can mean a number of different things. Justice can mean being given according to your rights. And of course, in an insurance-based healthcare system, your rights will relate to what your insurance policy says or what your National Health Service says is your right. So this will differ from nation to nation. Or the notion of your deserts, what people deserve. So, for example, people who attend health promotion clinics actually will be more likely to receive medical care than those who don't. And that's just a simple observation. For us as doctors, though, the most important notion of justice is needs. Will we use most resources on those with the greatest medical need? Will we seek out at-risk groups to ensure they get priority in medical care? I was absolutely fascinated to see in the interval between this talk and the last one with the rolling slides that you're having Professor Sir Michael Marmot talk to you. He is one of the very top UK doctors, if I can use that expression. And he's spent his whole career bringing to our attention in the UK the notion of health inequalities, that people who are poor, and we've got plenty of poor people in the UK, people who are poor are most likely to have the poorest health and most likely to receive the least access to health care. And as doctors, we must see that that's wrong and try and do something to correct that, to right that wrong. So as doctors, we need to be very concerned about justice. So we need to be concerned about justice in resource allocation. But the problem here is we have two conflicting principles. Because we know as doctors, each of us has a duty to do their best for each of our patients. And that's how we're brought up as doctors. And yet we also know as doctors that medical resources should be allocated to maximize the health gains of the whole community. And this, of course, is an example of so many of our ethical problems, that these two principles seem to be in collision. They conflict with one another. So I, as a doctor, must do my best for each patient, but I, as a doctor, must also make sure resources are allocated fairly across the whole community. How do I do that? None of us can do this on our own. So we need to have some system of resource allocation. There are principles. We need to identify the need within the community. We need to identify the existing and the potential healthcare capacity. And that will be very different from one country to another. And I'm well aware that in a country with major troubles, such as Yemen, the capacity of delivering healthcare will not be adequate to the terrible need that is there. So we need to assess what is necessary or practical to deliver any given service that we would want to deliver. We need to evaluate the likely impact of possible services that could be provided. And then we need to consult with colleagues and with the public in order to prioritize what we can give. So we can't do this alone. We can't say within our own little community, yes, I'm going to give you this and this, but no, I'm not going to give you this and this because I only have limited resources. We have to do this with colleagues. We have to do this with the community. We have to do this in a way that is transparent so that everyone can see what decisions are being made. And we have to do it with accountability to our professional structures, to our national structures, to our communities. We can only do this resource allocation if we do it together with others. There are two broad approaches of principle, though. One is a utility maximizing rationale. One example would be quality adjusted life years. And they can provide an absolute but possibly unfair answer where we are faced with difficult choices. They may not be just. Secondly, we can look at not so much a maximizing rationale, such as qualis, but a fair process, such as accountability for reasonableness is the title of one so-called fair process, which provide propose processes rather than calculations by which policymakers can consult the community and determine resource allocation. And these may be more fair, but they may not maximize benefit from limited resource. And to be honest, I can only scratch the surface of this issue. But what about our individual practice as doctors as well? There's a very important issue of justice here, and that is that we are doctors, not shopkeepers. This is not to disrespect shopkeepers. A shopkeeper should be honourable, but his job is to produce maximum profit for his family, as long as he does it honestly and within the law. A doctor must be honourable, and his job is to produce maximum health benefit for his patients. So you see the different way round that we're facing. Of course, a shopkeeper must be honest and within the law, but his job is to make money for himself and his family. A doctor, his job is to make health jointly with and for his patient. And so as doctors, we should make the care of our patients our first concern. So we need to be very, very careful that we're never giving a treatment because that treatment will also bring us some money. Because obviously our methods of payment may well be linked to the activity that we do. If we're to be proper doctors, we must always act only and primarily for the benefit of our patients and our own game. Well, doctors will get by. We are not the poorest in society. But this, of course, illustrates the point that principles may clash. For example, two principles that commonly clash are our wish to do something specific good for our patient, but the patient doesn't want that. So when principles clash, how do we work it out? Well, when principles clash, our actions need to be balanced by practical wisdom. And so that actually leads us to somewhere quite interesting. If as doctors we're to practice well, we need this sense of practical wisdom, and therefore it actually relates to the sort of people we ourselves are. Because doctors aren't just biomedical technicians. Doctors are professionals, and doctors have a moral responsibility. And a recent writer called Edmund Pellegrino has said that to practice wise medicine ethically, we need the right character traits. And he points out these traits: trustworthy and keeping our promises, wanting to do good, which we talked about, being unselfish, which we talked about, compassion and caring, which we've just a little bit talked about, intellectual honesty. So when we read the research, we have to be open about what that's showing and not just read things that agree with what we already think. Justice and practical wisdom. These are personal qualities that we need to be good doctors. And I would suggest that there are two controlling virtues in 21st century medicine. One is practical wisdom, or the Aristotelian word for that would be phronesis. Phronesis just means practical wisdom. As doctors, we possess many guidelines, and they're fine in straightforward situations. But the real world is too complex to navigate with guidelines alone. Phronesis is what we need. And I can imagine, I do not know in detail your situation in the Yemen, but you will have many pressures upon you, many resource limitations. And so some of the best practice that you'd like to give, you may not be able to give. You may well not be able to get your patients an MRI or a coronary stent or whatever. So how do you work out what is the best you can do? All of us as doctors need practical wisdom. And practical wisdom seeks the wise course in the patient's best interest, because the world is a complicated place. And we also have to remember that different patients have different priorities. Our job is to do what is in the patient's best interest, but it in many situations, we need to bear in mind what the patient's own life goals are, what matters most to them. So I don't mean pleasing the patient all the time, but I mean understanding the patient as a human being and what their hopes and goals and fears are, and adjusting our treatment according to that. So 2 controlling medicines in 21st century medicine, 2 controlling virtues, sorry. Number 1, phronesis. Number 2, no surprise, compassion. Compassion should be the second controlling virtue for the doctor. Compassion leads to care. If healthcare is not a caring profession, it is nothing. I have the honour of being a fellow of the Royal College of General Practitioners in the UK, and the motto of our college is Cum Scientia Caritas. With science, I care. I think that's a wonderful motto, because as doctors, we're scientists, but we're not technicians. We're professionals who care. And this, to me, is a vital virtue in 21st century medicine. Another way of looking at what is moral in medicine is the moral analysis of actions, and it has these 3 dimensions: who we are, and I've talked about our need to be doctors who care, doctors who are wise, doctors who are trustworthy and act justly, etc. But we also need to look at the nature of the act itself, and then the nature of the consequence of that act, the outcome of that act in the real world. As doctors, we need to be looking at these 3 aspects of any action. Okay, I'm going to draw this to a conclusion now. I'd just like to end with one other thought, really. I'm afraid the honest reality in our world is that ethics often works something like this. For many, many people in our world, self-interest, tradition and norms, and ethics all go together to making up group culture. I hope very much that as doctors, we are very much on that bottom arrow of primarily our actions are determined by ethics. I would suggest as doctors, though, we need to be leaders as well. As doctors, our job, our task is to make the world a little bit more like this. Of course, there will always be self-interest. And of course, we have traditions and norms that are almost always to be respected. But ethics, or morality, if you will, above all, should be something that we are trying to bring to the fore to influence not only our individual actions, but also our group culture as well. So I guess if there's one final conclusion I've got, it's that we ourselves are in the picture. We ourselves are in the frame, the sort of person we are. So if I can just say shukran, it's been very good to be with you. Thank you for listening to me. And that is my presentation done. Thank you very much.
Professor Misselbrook, thank you very much for your talk. It was amazing, and thank you very much for trying to make it, bring in an Islamic perspective, which I'm sure my colleagues in the Middle East and in Yemen will relate to that a lot more, because that's what they see on their daily practice.
Actually, could I say one thing there? Thank you for saying that. One of my jobs at RCSI was to teach ethics, but talking to my colleagues locally, I learned just as much as I taught.
Amazing. Thank you very much. One of the things that really touched me is the timing of this talk. A lot of, I remember going through medical school, ethics was the first thing we learned. On this conference, the ethical talk, we left it to the end. And that's on purpose, and that's really, there is a wise move behind this, is because we want this to be the last thing they remember of this conference, and stick the most. And I think that was perfect. Thank you very much for that. The other thing that I also would like to share with you and everybody else is, given the circumstances our colleagues are working in Yemen, lack of resources and very poor maybe incentives in terms of payments and wages and stuff. A lot of people may cut corners and may seems to be unethical for us. But one thing, if I was in the issue, what would I do? And it's very important for us not to be judgmental against these doctors, because they are in very exceptional circumstances. They are very good people, but sometimes the situation they're in prevents them from doing the best they can do. However, having these talks reminds them of how to be the best you can ever be given the circumstances. And I think it just goes in nicely with your talk, and I'm sure we'll have lots of Q&As from my friends who will maybe, echo in similar thoughts.
Thank you. Did you want me to respond to the question on the chat?
Yeah, so there is a question here. I mean, they ask questions in the chat, and some of them are the Q&A session, and there will be some coming from the YouTube channel. A lot of people are making comments on regards rather than questions on the Q&A. On the chat there, so some, how can Right, okay, so it's very good to see your interest in Yemen to be ethical. Sometimes I think that doctors in Yemen just forgot that we are supposed to be ethical. How can we make sure that my friend doctors are ethical in Yemen when there is so much corruption everywhere? I guess that kind of goes in with, yeah.
It's interesting. See, from a Western perspective, some of you in your training may have heard of a Western moralist called Immanuel Kant. Now, to Immanuel Kant, there are many things in this world are just black and white. You must always do this, you must never do this, and that's an end to it. And that's, interestingly, one of the reasons why I said that the traditional Islamic model of, if you like, a sliding scale is actually much better, because the world has so many grey areas. The world is not black and white, or rarely black and white. The world has so many greys. And so this is why we need practical wisdom. We need practical wisdom because there are often choices forced upon us which neither side is really what we would want. Neither choice is really what we would want. And therefore we need practical wisdom to try and find the best way forward that we can. So sometimes the best way forward that we can is not what we would want. It's certainly not a perfect way forward, but we do our best as humble and fallible humans to negotiate a pathway, and that pathway will be determined by the medium and long-term issue of what is in the best interest for our patients. So it's not in the best interest of my patients if I sort of pull myself up to a great height and say, I'm a perfect and righteous doctor and I will never go into a grey area, because I won't last very long as a doctor. But neither is it okay to say, oh, well, the world's just a terrible place, I've just got to go with the flow. It's partly my job to try to create a better culture. If I'm an honest man and a compassionate doctor, then I can be part of trying to create a better culture. I might be able to push the bus only 1 inch up the hill, not very far. But if I'm pushing it in the right direction, rather than just watching it slide down the hill, then I'm doing what I can as a human being and what I have been put here as a doctor to do.
Thank you very much. So it goes back into that practical wisdom, which is
Absolutely.
a really good concept to summarize all, really.
Absolutely.
And everything underpins what we discussed, I guess, for my colleagues in Yemen, just to think about how can I achieve that practical wisdom? The second question actually ties in really. It says when the doctor is poor and has to support their family, how does he balance the need for money when he sees his patients? I guess we're trying to say, there will be patients who are less well off, maybe cannot afford treatment. How we can balance that, because the doctor soon will be unable to support his family if he stops charging people, taking fees.
Well, I'm immensely fortunate to be brought up in the UK, which is a wealthy country, and so I should be asking you or my colleagues this question, not you asking me. But what I would say is that if we look back in the UK 100 years before the National Health Service, and in Victorian times, more than 100 years ago, the rich were very rich and the poor were very, very poor. And the way doctors functioned then was that they charged full fees to their rich patients, and their poor patients they treated for free, or if their poor patients could give them, a couple of vegetables or 3 eggs or whatever. That's the way the country doctors worked in this country 100 years ago. And so I think the general principle would be, of course, you need money to feed your family, but a doctor in a community should not strive to be wealthier than the community. A doctor in a community shouldn't strive to be the rich guy. A doctor in a community should strive to be part of that community, feeding their family, but trying to help the poor charitably as much as they can. I mean, that's part of the tradition of zakat, is it not? So, any and indeed in my own country, that would also be part of a tradition, although the words we use would be different. So I think that's the best answer I can give, that we are part of the community we're in. Whatever community we're in is going to be muddled and not always righteous. And we must do our humble best to show compassion, and especially compassion for the poor.
Thank you very much. And then a question which again is a bit similar. So when there are not much medicine available, who do you decide, who to give in terms of, who gets what and when? It's all kind of trying to manage the limitation resources.
Yes, this is a terrible decision, isn't it? I think if one is part of a community with community elders or with other doctors, as much as possible, decisions like that should be shared, because they're a terrible burden morally on an individual. But I think the principle should be where it will do most good, where there's the greatest need, but also where that intervention will produce the most benefit. So what we're talking about here is triage. The general principle of triage is some people actually don't need immediate attention. They'll get better by themselves. And if they're wealthy, or if they're making a lot of noise, or if they think they're a powerful person or whatever, well, actually as a doctor, you've got to turn your attention to the person with the greatest need, in as much as it's possible to do that. Some people actually you can't really help. In a battlefield triage situation, there are some people who are going to die, and if there's somebody else, for example, in a medical context, a nurse or a family member or whatever, who can just comfort them, then you're best to move on to the people in the middle who you can help. So it's not the people making the most noise, it's not the people who you can't help, but the people where you've got a maximum chance of doing some good. That I think is in principle where you would want to put your resources. But again, I say in principle because, nothing in this world is straightforward.
Absolutely. And, and I would like to also let my colleagues in Yemen know that we sometimes face this in the UK as well. For example, during this COVID pandemic, when right at the beginning, when we had very limited number of ITU beds and ventilators, we had, personally not me because I'm not an intensivist, but our colleagues had to take that into consideration and decide, who is going to have a ventilator and who is not going to have a ventilator. Luckily, we didn't have to do that for so long. And as you say, the principle is the same, making it a shared decision rather than, the whole burden lies on one individual. So the principles are the same, and the situation can happen to anyone anywhere. Of course, it happens way more often for them in Yemen. And we hope things will improve soon for them.
This is why your colleagues in the Yemen should be giving lectures to us.
We hope through INTERYem we will get our colleagues in Yemen to have a platform, especially when we get to the research aspect, when we collaborate with them to collect real data, equip them with skills where they're able to analyze it, present it, because there's so much wealth of experience we can learn from them. It's just that it's not part of their training, and also it's the last thing they worry about. So hopefully through organizations like INTERYem, we will nourish the research aspect of this, and maybe in a couple of years' time we will see some studies coming out and we can learn from that. So one question here, which is I think is a really interesting question. As you've been in Bahrain and UK, what do you think is the biggest ethical problem you have seen, and what was done about it?
Oh gosh,
loaded question there.
Oh, I didn't see that question anywhere. So as the question says, in Bahrain, presumably it means in that region.
I would assume so. Yeah, I would think so. Have you noticed that different ethical dilemmas between UK and Bahrain? And
there are.
Bahrain is probably like representation of the Middle East, right? To be honest.
Yes, there are some, but to be honest, most of our ethical dilemmas we share in common. Obviously, the Yemen specifically is in a war situation, which is a very terrible situation. So that puts immense pressures on the system. But if you think of the Middle East as a whole and the West, I would say we hold most of our ethical dilemmas in common. My personal opinion is the single biggest ethical dilemma we face is that of the corruption of our evidence base by the influence of the pharmaceutical industry on the research outputs. And the longer I've looked at this, the more concerned I have become. And this tends to drive medicalization, inappropriate medical treatments of things that do not always need treating. Well, for example, I absolutely loved the lecture earlier by Professor Arrell, pointing out that the large majority of people with mild to moderate depression would do far better with psychological treatments rather than antidepressants. But our evidence base has been so distorted by the effect of the pharmaceutical industry that what we actually tend to do, and also because we don't have time as well, is we prescribe these folk antidepressants, whereas it isn't necessarily the most beneficial thing for them. So I think that's one big issue that I have become increasingly concerned about. But that, of course, is from the perspective of high-income countries, Bahrain, most of the Gulf and the West all being high-income countries.
Yes, thank you. And also with regards to the pharmaceutical and the evidence out there, I got involved into diet and exercise, and had to actually look at the evidence which was presented to me as a student, and you think, oh God, there's so much, flaws in that research. How did that become guideline? How did that become accepted to be taught in undergraduate training? And I think it's something we have to be mindful of, to be honest. Yeah, something which hopefully will become more and more as we are able to share knowledge more better and easier than maybe 20 years ago, 30 years ago. Those things hopefully will not go unnoticed like they used to, but they do exist.
Yes, I do hope so.
This is another interesting question. Compliance with medication. So this is I think this is more typical for the Middle East patients, as you give them medicines and they take it, they may buy it, but they don't consume that medicine. There is almost a fear of medication. There is, they are afraid to take it or think that it has more harm than good. And this, one of our colleagues asking, how can they tell the patient to make sure that they take their medication?
Well, I think it's very interesting the way in which we even ask this question, because we're not our patient's boss. We have to listen to our patient's concerns. So the patient will have health beliefs. So the patient will have something in his mind. So if a patient isn't taking his medication, there's a reason why. It will be logical to the patient why they're not taking the medication. And there's a lot of literature about this, and we can read the literature about this. And it's to do with health beliefs. So we've got to start by listening to our patient, basically. And it's only when we listen to our patient and take what they're saying seriously that we stand any chance of building this bridge between their health beliefs and our health beliefs. So by and large, in almost all cases, it's no good us saying, you must take your medicine, because they'll be with us for 10 minutes and then they'll go away again and live the rest of their lives without us being in the room. We can only get anywhere if we listen to them, and if we ourselves come over as people who are trustworthy and compassionate. If a patient believes us to be compassionate and trustworthy, they're more likely to believe what we say when we say, actually, it really is in your interest to take these medicines. Of course, the other big issue might be that of being able to afford the medicine.
Absolutely. It's all that down to the relationship between the patient and the doctor, and how strong that is. And patient will, some patients, if his trust is there, they will follow the doctor blindly. They will do anything to
some will. Some will and some won't.
Yeah, but I just would like to also let my colleagues in Yemen that even this happens in the UK. So I remember when I was a young student doing my GP placement, there was a tree outside our GP surgery, and the tree had a little bit of a hole. So one time they needed to knock that tree and make space for a building. And when they cut the tree, inside the tree, there were so many GP prescriptions accumulated over years. So the patient will basically take the prescription from GP on the way out. They will stick it in that tree.
Wonderful. Yeah.
That's a true story.
Yeah.
So
well, and most of us, all of us as family physicians doing home visits, so particularly if a patient has died and it's our job to clear out the medicines to make sure there aren't dangerous medicines sitting, we'll find cupboards full of medicines and so on. And the point is, it's the patient who makes the treatment decision. We think we make the treatment decision. No, we make a decision to write out a prescription. It's the patient who makes the treatment decision. So it's our job to sit down, to listen to them, to be a trustworthy person who they find to be compassionate, and then they may make a treatment decision that is in line with the treatment decision we think we've made.
Absolutely, thank you. This is quite a very frequent dilemma, ethical dilemma that happens in the Middle East, and that is when the family members don't want the doctor to tell the patient that they have a serious diagnosis like cancer. So this person is asking, what should we do in that situation? So the family know, they don't want the patient to know because they think it will make the patient sad.
Yeah.
And the person asking is asked on behalf of a colleague. So I'm not surprised this happens a lot.
No, absolutely. Well, I'm old enough to remember that that was the exact situation in the UK when I started in medicine in the middle of the 1970s. I remember my own teachers at Guy's Hospital in the 1970s. Some took this position and some took the other position. And it was very interesting to see how that worked out over time. What I would say is if everyone is lying to each other, the patient will die isolated and alone. The patient will come to realize that the family are lying to them. Then they can't then anymore share with the family openly. The patient will realize that the doctor has been lying to them and they will lose trust in the doctor. The patient will die alone and in desperation. So I'm not saying that you just blurt out all the bad news instantly. There are ways of sharing bad news. There would be two things I would say. Firstly, where there is this culture of trying to protect the patient from bad news, it's not in the patient's interest. And it's a culture that as doctors, we need to try to change over a period of time. But secondly, for my own students at RCSI, I said the thing for them to do is to always, 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 always have good communication skills and talk to the patient first. If, for example, the patient comes out of an operating theatre and the relatives are there and saying, what's going on, how are they, and the news is bad, once you've shared it with the relatives, there's nothing you can do because they will say, you mustn't tell them, doctor, and so on. So always, if we're talking about an adult with capacity, if it's humanly possible to do so, sit down one-to-one with the patient. And there are ways of breaking bad news. First, you want to know what they want to know. Okay, so I've got some results for you today. Now, what do you know so far of the situation? Well, I've got these results. Would you like me to explain these results to you? Would you like anybody else to be here with you? But you ask the patient that. You don't ask the family whether they all want to be there, because of course they do. You ask the patient that. And that's how you start. But you don't change a culture overnight, just as my teachers didn't change the culture in the UK overnight.
Thank you very much. I think that's really, really important. It's a culture change.
Yes.
And we are very lucky to have some deans of medical schools attending and listening to us. We have some policymakers, and we hope they will put that in their undergraduate curriculum so that the future generation of doctors and these countries know that it's the patient who comes first, and that relationship between the doctor and the patient has to be sacred. If that is right, then compliance with medication and all that comes as a byproduct. But when we start lying to patients because the family wants so or the culture may say so, then it has a domino effect in every aspect we do. That trust is crucial for us.
Do you mind me saying Helen Crawley has raised her hand?
Yeah, I've seen that earlier actually. I'm not sure if it's intentional.
We're still here, so I'm wondering
Dr. Crawley, are you with us? Would you like to say something?
She's still muted.
You would be able to unmute yourself because you're on the panelist. So, oh yeah, excellent. We can.
To be honest, it was completely unintentional. I must say, I've really enjoyed this. I'm on a run. I'm out running and listening at the same time. But I have to say, I thought this lecture absolutely crystallizes what is fundamental to good medical practice and particularly good general practice. So thank you for that.
Thank you, Helen. And while we're talking about each other, could I just say to all our colleagues in Yemen that the Royal College of General Practitioners in the UK has been such a positive force for us as doctors in supporting the way we practice. And I think the notion either of setting up something similar or of seeking collegiate help from the UK college, because the UK college does interact with other countries. I think that would be a hugely valuable thing to do. That's just speaking from my own experience.
Thank you very much.
Do you mind if I answer off my own bat the very last question there, because it's so interesting?
Yes, absolutely. Please go ahead.
The last question says, Professor David, in your country, the people are not allowed to leave the house because of coronavirus, but in Yemen, the people are doing everything. Are we not right in Yemen because we respect the autonomy of the people in Yemen? Wonderful question, wonderful question. If I could make a very slight correction, we are allowed to leave the house, but there are lots of things we're not allowed to do. We're not allowed to gather beyond one household. Except now in the garden or whatever. But this is a brilliant example. I'd like to answer the other question as well, if I may. This is a brilliant example of having to balance different aspects of what is moral. It's a brilliant example of individual autonomy versus justice. You see, if we all did what we wanted and gathered together and just went about our lives as normal, the vulnerable people in our society would die. Not all of them, of course, but a large number of them would die of COVID. And in the UK, 125,000 people have died of COVID. And we've only kept that number down by healthy and middle-aged people like me and younger people restricting what we do. And the government has a role in that. The government has a fair and right role in that. And we might agree with them, we might disagree with them, but their job is to try and balance the needs of the individual against the needs of society as a whole. And I don't think there's any one answer. And so I'm certainly not saying we've got it right or whatever. Do you mind if I just very quickly, because we must be out of time, the next question was, how do you develop culture of ethics in an environment that is not familiar with ethics? Well, if you don't mind me saying so as a Westerner, I do not believe your culture is not familiar with ethics. You're an Islamic country. So it may be that what one needs to do is actually to reach back into one's tradition. And, you know, I've just put up a couple of slides with just tiny little bits of Islamic teaching on, but I mean, you know far better than I the depth of Islamic tradition that talks about justice, that talks about how we should relate rightly to one another. So I'm not saying everyone should, you know, a doctor should be an imam, of course not. What I'm saying is a doctor should be able to reach into the tradition of their own culture, that which is best and that which we know is right, and actually, you know, say what we know to be right. We should say, you know, this, my brother, I believe, you know, my friend, I believe that this is the better way of doing things for this reason. And as I say, you know, I might push the bus 1 inch forward, but if all of us are pushing the bus, then even if we only get a little way, we are doing what we can, and that's the best that I know.
Thank you. I think the questions are still coming. Would you like to take just one question out of these, whatever you feel is the most?
That's fine. What do you feel, Dr. Wahib?
To be honest with you, I think they keep coming. And to be honest with you, some of them are similar. So, you know, for example, the last question about patient education, this is probably more for public health and awareness, which we will have a public health conference, which I will talk about at the end. There is a question which I think is further down the top. If you see a colleague taking bribery, how do you deal with that? This is now in Yemen. So the question is, what's your advice when we see nurses and doctors are forced to take the bribe because they are poor? So there's something that probably very important for them, because they probably come across it, unfortunately.
Again, I would love to know what my colleagues, my brothers and sisters in Yemen would say to me about this rather than the other way around. But for what it's worth, I mean, my approach would be to try, if it were possible, to have a low-level and non-judgmental discussion with that doctor. You know, my friend, I've noticed that you take these bribes. Can you tell me how you feel about that? You know, in my heart, I feel this is not a right thing to do, but I know that there must be reasons why you do this. And to take that sort of approach and to attempt to discuss it in a way that's culturally acceptable. Because as I say, you know, we can't suddenly stop all the wrongs in the world. But if we can have a positive effect on those around us, to take a more, I'm going to stop using the word ethics, because it is about morality. And, you know, I completely don't accept that. I mean, I understand some of our colleagues saying, well, we just don't see a lot of ethics in Yemen, but there is a moral sense in all of us, and very often a stronger moral sense in some of my friends and colleagues in the Middle East than I sometimes see here in the West. And so it's a matter of trying to talk to one another and influence culture in the direction that we already know is right. You know, we're not bringing something new in by medical ethics. We know what is right. Sometimes you have to sit down and think about how it applies in difficult or complicated situations. And sometimes we certainly have to use wise judgment, because the world is a messy place. In fact, one of my favorite lines from Beecham and Childress's book is a very simple line. It says, the moral life is messy. You know, it's not simple black and white. We have to make difficult judgments. But if we can push our culture in the right direction, then we're doing what we can. And it's about time I stopped talking, I think.
Thank you very much. It was a pleasure having you on our conference. We learned a lot, and you reminded us of really important moral fundamentals for our practice. And also, I like the bit about practical wisdom, something that would resonate with me for a long time. And I'm sure our colleagues in Yemen would also, because it's probably something I haven't heard before and they haven't heard before. Practical wisdom, just balance and everything, and going back to that morality and basics of human nature. And also as a responsible clinician with that privilege of being able to make a difference, and at the same time, hopefully not do harm. Thank you very much. I think with great sadness, I'll have to bring this to a conclusion. It's been an interesting conference, spanning 2 days over Zoom and YouTube. We had 15 keynote speeches from amazing guest speakers from 3 continents. We had from Australia, Africa, Europe, Middle East, actually 9 countries. We had guest speakers from over 9 countries. And they all condensed and concentrated their years and years of experience into one talk, so that we can understand more about family medicine and how it can help our colleagues in Yemen. And also, we had great engagement from our attendees with lots of Q&As, and you can see that we struggle to go through all of the Q&As within the allocated time. But hopefully all these talks will be recorded and you can go back to them at your leisure. I would like to thank the speakers one by one. So we had Professor Michael Kidd and Professor Grant Russell from Australia. Then we had Dr. INTERYem and Professor Marsh from Ghana and from South Africa. And then we had Professor Ali Batarfi and Professor Fawzia Mansoura Fuad from Qatar and from Yemen. Then we had Dr. Wafa Haj, Professor Basalim, and also Professor Abu Talib from Yemen and Saudi. Then we had a presentation of a project from Dr. Najla Al-Gariri. And today we had Professor Arul from New Zealand, and then back home with from the UK, Dr. Holmes, Dr. Crowley, and Professor Fuad and Professor Misselbrook. Thank you very much to all of you for your time, and all the points you have shared with us, your suggestions, your teaching. Myself learned most about myself and also my colleagues, and I'm sure our attendees as well. I also would like to thank all of those who attended. We tried to make this as convenient as possible with lots of breaks and having the ability to record this for your future viewing. If anybody would like a certificate, please email us. We'll send you a feedback link. Once that's completed, we will forward the certificate to you. The certificate only available if you can show us that you have attended or either live or recorded at least 75% of the conference. Just to remind you that we are INTERYem, which stands for International Network for Training, Education, Research for Yemen. It's a small organization that started in 2014 and slowly picking up pace. Our ambition is to facilitate collaboration between colleagues in Yemen and the rest of the world. We hope to do this through exchanging ideas, sharing expertise, and building friendships to improve the education and training of healthcare professionals in Yemen. Ultimately, this is all to help the health of the people of Yemen. There was lots of points to learn from this conference, and we have achieved what we intended to do, which is to help our colleagues in Yemen understand more about the importance of family medicine, see examples of experience of family medicine from different countries that have similar infrastructures, but also create that collaborative network with leading experts from those countries that can later help in setting up any aspect that will help. With regards to research, we always encourage research, and one thing that I was thinking of when I was listening to the last talk is consent. In Yemen, written consent it's not something that I have come across, and I think maybe the family doctors in Yemen can lead into teaching their colleagues about consent, and maybe they can start generating standardized consent forms and conduct some training, and would be helpful to take you through this and help you get into a research principles course to be able to conduct something similar. We hope that you will join us for the next conference. I will just try and share my screen so that you can see the program of the next conference. Okay, Mubashir, if you could please enable my account to share the screen. So again, a similar conference over Zoom and YouTube with leading experts from all over the world. Okay, you should be able to see it now. Okay. So that's the poster. So the date has been finalized. So we'll look forward to see you on the 9th of April for the Public Health Conference. If you have any comments or any questions, or any feedback, please remember to fill the feedback forms. We'll be looking forward to see what you think. All points raised will be looked at and hopefully implemented to improve your experience in our next conferences. Thank you very much for being with us, and we wish you all the best. Assalamu alaikum wa rahmatullah.